Hiren has been very lavish in his introduction of me, but yeah. Uh, well, the aim, why I decided to take this master class for you all was basically because considering the diverse people who are attending this forum, a lot of you might get small kids with congenital heart disease. And some of you might be in far-flung areas and patients have to travel a long distance to reach our facility. So I thought this class will help some clarification in the mind of all doctors, especially general practitioners, pediatricians who would be seeing these kind of cases and who would at some stage decide, yes, look, I should know when to send this baby for heart surgery, or till what time can I keep the baby under my care and then refer him forwards. So considering all that, this class becomes very relevant. I know it seems very complex and complicated in the beginning, saying that the congenital heart surgery and small babies and heart defects. But I've tried to keep this class fairly simple and fairly straightforward. So first of all, let me start with introducing what is the burden of congenital heart disease in India. See, we have a huge population, 1.4 billion people, and the birth prevalence of congenital heart defects is 9 per 1,000 live births. Considering this number, the average yearly births in India with congenital heart disease amount to almost 240,000. And this number, believe me, is a huge number. I mean, it is probably one of the largest congenital heart disease load in the world. And we have very limited facilities to take care of it in a proper manner. So all in all, these congenital heart diseases become a tremendous load on society, parents, the healthcare system. All in all, the healthcare infrastructure in the country can get very rapidly overburdened with this disease. So it becomes all the more important for physicians to know that, look, for this much period, I can safely look after this child and then send him for surgery. An unnecessary referral to a tertiary care center can increase the load in that tertiary care center to the extreme where the system can break down. So all in all, this load of congenital heart disease in India, even today, with the world-class centers we have, still causes a 10% addition to the infant mortality rate of the country. Let's look at the Western data. Now, Western data says that the prevalence is almost the same in the Western countries, although with the fall in fertility and the fall in number of births and increase in population, I mean, rather the static nature of population in most of the Western world, the developed countries are seeing a lower and lower load of congenital heart disease. Also, about 99% of these are diagnosed before birth in the primary.
आता साफसूफ करत चढलं तर फोन आला ऑपरेशन.
Gaurav, unmute yourself.
You are not audible.
1.5-year-old is still kind of slow, except for the
Somebody is trying to mute and unmute me. Now, am I audible now?
Yeah, now you are audible. Yes, yes.
So I restart the whole thing, or I got muted on the way.
Yeah, you are on this slide. You are on this slide of Western data.
When somebody muted me.
This one.
Okay.
Yeah, you were on this slide. Yeah.
Okay. So you heard what I spoke earlier, is it?
Yeah. From this slide, we have not heard. Yeah.
Okay, so where I was getting at is that the prevalence is the same in the Western world, but what the difference is that there is a hidden some other mic is open, which is disturbing quite a bit. Anyway, so the prevalence is the same in the Western world, but the in the developed countries, almost 99% of congenital heart diseases are diagnosed before or at birth. That is one. The second thing is that there's a fall in the fertility rates in the Western world, a phenomena which we might see in the next 20 or 30 years, but what has already happened in the developed world. So the load of congenital heart disease is very limited. The health infrastructure is extremely good. And almost all babies with congenital heart diseases undergo treatment at the correct time, which is not the case in our country for various reasons. One being that the pediatric cardiologist and adult cardiologist outreach in the peripheral areas is very poor. There's a huge concentration of extremely trained people in the central areas and metros, not so in the periphery. So there's no primary health diagnosis for these patients. The the second thing being that the understanding. So what goes along with this poor outreach of trained personnel in the periphery is the general physician or the primary health giver in the periphery has very little understanding of what goes in a management of or a diagnosis of a congenital heart disease. Basically, because our medical training also does not concentrate too much on congenital heart disease. Is after all only one chapter in pediatrics, which most people run away from. We do have many guidelines and consensus statements regarding what is the ideal treatment for congenital heart disease, when they should be treated, when they should be referred, what are the options, surgery, medical management, intervention. But most of these are from developed world, and they're not really applicable to the Indian scenario because of many considerations. First, being resource limitation. We don't have that kind of facility in every place, which we are able to give to the patient. There's lack of data, lack of legal and government regulations as to who can do congenital heart surgery. As a result, a lot of peripheral centers it's being tried with very suboptimal results, or some basic intervention is done and the patient is told that look, you're treated, and then they land up at a tertiary center many years later in terrible conditions and not able to undergo proper treatment. So it's a very precious life lost, or precious quality of life which is lost. What's different in the Indian scenario is one, of course, as I've been talking, incomplete understanding, delayed referrals. On top of that, our kids who come from the peripheral areas are malnourished, they have infection, anemia, they're underweight. So all in all, this results in a lot of delayed presentations, pulmonary hypertension, which is very high, which decreases, the poorer outcomes of the patient. There's ventricular dysfunction because of this long-standing heart diseases, hypoxic myopathy because, again, of this long-standing cyanosis, polycythemia, joint disorders, developmental delays. The list goes on and on. So considering all that, in 2016, Anita Saxena from All India Institute started this great initiative with the top few names in the country to make a consensus statement which is more fit for our scenario as to when and how we should treat our children with congenital heart disease. So the aim of my talk today is to present to you and make you understand the optimal timing of intervention in congenital heart disease, discuss a few issues related to malnutrition and infection, and over a period of time, try and evolve referral modalities in this very sick babies so that every child anywhere in the country gets the best possible cardiac care. So basically, I have divided congenital heart diseases to simplify it. If I go disease by disease, the lecture and the list can be endless. So I made it simple, left to right shunts, which means it's an increased pulmonary blood flow situation along with heart failure. Right to left shunts or cyanotic heart disease and obstructive lesions. Obstructive lesions I'll not cover today because in any case, all these patients come in terrible state first up to the primary health caregiver and they are referred in any case. So what I'll tackle today is the left to right shunts and the basics of cyanotic heart disease. So left to right shunts are what we call the acyanotic heart disease or disease with increased pulmonary blood flow. And the basic features of this disease are failure to thrive, the baby does not grow, symptoms come in the early or mid infancy. And the classical features are features of heart failure, which is poor feeding, poor growth, what we call the mother or the relative will come and explain to you that the baby has palpitations, fast breathing, sweating while feeding, and the classical symptoms of suck, rest, suck cycle, which means that the baby starts suckling, starts feeding, gets tired because of the effort of breathing, along with the feeding, stops for a little while, rests, catches its breath, and starts feeding again. So what we read in our MBBS, the suck, rest, suck cycle. Well, I'll start with the simplest of the defects. That's the atrial septal defect, or what we call the ASD. Although it's the simplest of the defects, it's not the most common. It's the second most common congenital heart defect, the prevalence of about 56 per 100,000 live births. If you start looking at this diagram on the left-hand side of your screen, on my right-hand side, which I have, the upper part, that the interatrial septum has a hole which may be of varying size, and there's a lot of blood flow from the left atrium into the right atrium, goes into the right ventricle, makes a circuit to the lungs, and through the lungs back again to the left atrium. And this circuit goes on and on, causing a volume overload of the right side of heart and the lungs, which are very heavy. It is 15 to 20% of congenital heart diseases. Spontaneous closures of these defects are rare. So that's one thing which all of you must understand, because a lot of times these babies come to us, various holes in the heart which come to us, sometimes in inoperable stage, that no, I had seen a doctor since birth, but the doctor told me that this defect will heal. And it does not happen. And then the child Eisenmangerizes as the age goes, and then in the end becomes inoperable. It's a very sad situation of a very simple solution could have been offered, but we'll end up with many babies who have grown into teenagers or young adults with Eisenmangerization. So as I said, spontaneous closure defect more than 8 millimeter or after 2 years of age is not a possibility. But happily or luckily for the patients, pulmonary vascular disease, irreversible pulmonary vascular disease occurs only at 20 to 40 years of age. So there's a huge time period in which the baby can be treated. We classify these ASDs as ostium secundum ASDs. This is just for your knowledge. Ostium primum ASDs, sinus venosus ASDs, and coronary sinus ASDs, with the ostium secundum ASD being the most common, which is shown in the diagram here. So what are the diagnostic features? Common diagnostic features, basically, again, not so much features of heart failure, but still failure to thrive. The child will be small, 4 or 5, 6-year-old child, small for his age. Some sort of medical has been done at some stage in preschool period, and somebody has picked up an incidental murmur. You get a chest X-ray done, which shows increased vascular markings. An echo shows a dilated right atrium and right ventricle with dilated main pulmonary artery, and a defect in the atrial septum with a left to right shunt. So the indications for closure in an atrial septal defect: any patient who on echo shows an evidence of right heart volume overload with no evidence of irreversible pulmonary artery hypertension is a candidate for surgery. And the timing for surgery. So this is important to remember. In an ASD, the timing for surgery is much later in life than a ventricular septal defect. And a lot of times we get referrals, 6-month-old babies, some echo has been done somewhere, and the baby is referred for surgery. And it's drilled in the parents, no, it's got a hole in the heart, you must get it operated. And the parents want to get it operated. Well, there's no indication for surgery unless the baby is symptomatic. So in a symptomatic baby, the Indian recommendation is surgery between 2 to 4 years of age, or what we call the preschool age. If patients are symptomatic, then there's features of heart failure, then surgery should be offered earlier. If the patient presents beyond the ideal age, surgery should be done at the earliest. Or if by chance there is some clinical feature of neurological injury or neurological event because of a paradoxical embolus, that is a embolization which has occurred from the right side to the left side, contrary to the blood flow, the surgery should be offered at the earliest because the patient might have a similar second episode of TIA. Now, the second disease, which is much more common and much more fatal early in life, is a ventricular septal defect. So on the right of the screen, you will see a normal heart in which the interventricular septum is septated. Whereas on further right, you see an abnormal heart with various levels of defects, which are the various levels of ventricular septal defects. So it occurs in 20 to 30% of all congenital heart disease. So it is the most common congenital heart disease found in all age group, 3 to 5 per 1,000 live births. And 10% of large ventricular septal defects die within 1 year with congestive cardiac failure. So this is a really, really large number, and this large number should be really taken into consideration when you see a baby with a VSD. Yes, in this cases, spontaneous closure can occur. This you must remember, that in a small VSD, a spontaneous closure can occur, but I think that decision to follow up that VSD should be left with a doctor or a pediatric cardiologist at a tertiary care center. Again, I say that spontaneous closure is uncommon in large VSDs or malaligned VSDs, or VSDs which occur in the inlet region of the heart, which is this area, inlet region near the valves. Is very uncommon. So now, how do we classify this VSD so that you know which one may close or which one may not close? So a small VSD is classified less than 1/3 of the aortic diameter. These are all echocardiographic criteria. And right ventricle and pulmonary artery pressures are normal. And anything larger is moderate or large VSDs. So let's come to what are the indications for closure and what is the timing of closure. So if there's a small VSD, again, keep going back to the previous slide or keep on thinking about that small VSD. Generally, a small VSD baby will be asymptomatic. He'll have normal PA pressures, normal dimensions of left-sided heart chambers, that is left ventricle and left atrium, normal size on echocardiography, and the aortic valve is normal. Well, you can do a annual follow-up till 10 years of age, and a closure is indicated if there is infective endocarditis because of that blood flow across the VSD, or the aortic cusp starts prolapsing and causing aortic regurgitation. A moderate size VSD, which is less than the size of aorta, half the size of aorta, is if they're asymptomatic, you can wait up to when the child grows, maybe 2 years or 3 years, and then send him for surgery. However, if he's symptomatic, the baby is symptomatic, and if controlled by medication, then 1 to 2 years. If symptomatic, even on medication, then as soon as possible. A large VSD will never give you a choice. The babies will have poor growth, very small for their age, falling down on the curve, congestive cardiac failure, the clinical features as I explained to you. And if they're controlled on medication, we prefer to go up to 6 months. But if they're not, then as early as possible, even 1 month, 1.5 months, 2 months, 3 months, whatever is the weight, because the weight will not increase till the time you close the VSD. So a lot of times I've again heard this thing from the parents that we went to a doctor, but the doctor said, let the baby grow, it's safer to do cardiac surgery then. But with a large VSD, the baby will never grow. He will have multiple episodes of pneumonia, and in one of those episodes of pneumonia, we'll lose the baby. So a large VSD with poor growth and congestive cardiac failure, please refer for surgical option. A VSD with aortic cusp prolapse should be operated as soon as any aortic regurgitation is evident. Well, the third entity with on the left-right shunt is atrioventricular canal defect. I don't know, all of you who might have heard my earlier talk on AV canal defects. This is again quite a common congenital heart defect, 4 to 5%. Types are complete, partial, intermediate, and unbalanced. What an AV canal defect is, again, as if you can see the cartoon on the right, the common area between the intraatrial septum and the interventricular septum is missing, and that is what we call the endocardial cushion. And the diagnosis is atrioventricular canal defect. These babies seldom wait. If it's a complete AV canal defect, they never give you time. The indications become for surgery as for a large VSD, that is whenever there are features of congestive cardiac failure earlier than 6 months of age. Partial or intermediate AV canal defect at 2 to 3 years of age, but earlier if possible, because as we delay the common AV valve, which is the mitral and the tricuspid valves are common, and these valves start getting deformed and you can never get a proper repair. The fourth lesion with a left-right shunt and which can cause heart failure and failure to thrive is a patent ductus arteriosus. So as you all would know, the aorta and the PA are connected in the intrauterine life by an open ductus, which closes spontaneously after birth, but does not close in a few patients. And a large to moderate PDA with congestive cardiac failure and pulmonary arterial hypertension requires early closure, whether by device in the cath lab or surgically. More and more PDAs are now being devised with more expertise at the hand of cardiologists, and smaller and smaller intervention equipment available, and very few PDAs now are candidates for surgical closure. Silent PDA is a PDA which does not cause any murmur and not showing any features, clinical features, and is picked up incidentally on echocardiography. And these, as of now, the recommendation is no closure is recommended. Well, that takes care of majority of acyanotic heart disease with right to left shunt, where the predominant features are heart failure, and the risk, if these patients are left inoperated, is of Eisenmangerization, recurrent pneumonitis, and irreversible pulmonary vascular damage, which we call as Eisenmenger syndrome. Do we take questions now for this subset, or do you want me to take all questions later, Hiren? Okay.
Sir, we can take later.
Okay. So I'll carry on with the second part of this topic, which is right to left shunt, what we call the cyanotic heart disease, because in these patients, the impure blood from the right heart is being shunted to the left side of the heart and hence into the systemic circulation, causing a drop in saturations. And most common and the most famous disease in this subset is tetralogy of Fallot. It's the most common cyanotic heart disease, 0.4 per 1,000 live births. 5% of all congenital heart disease, which, as we read, I think that's one of the things we read by heart when we were doing our medical course, is a large VSD, which is malaligned, aortic override, malalignment of the infundibular septum, and right ventricular outflow tract obstruction. We all marked it verbatim in our MBBS days. So basically, the clinical features are straightforward. The baby is blue. The baby doesn't get blue at birth. Very rarely it gets blue at birth, but most common is about 3 to 4 months of age. When the baby starts turning, becomes more active, the pulmonary vascular resistance falls, and the baby's oxygen demand outruns the amount of blood which is passing on to the lung. And then is when these babies start getting blue and start getting what we call the TET spells or hypercyanotic spells. So the presentation basically varies by the severity of the right ventricular outflow tract obstruction. The more narrow the outflow tract from the right ventricular to the pulmonary arteries is, the more the baby is symptomatic. If there is any other source of blood supply, say a PDA, then the baby is less cyanosed. If there is no PDA, the baby will be more cyanosed. The size of the native pulmonary arteries, they are also underdeveloped in these babies. So what is going into the lung, that is also has a very important bearing on how much cyanosis the baby is. And basically, cyanotic spells are the defining clinical presentation of these children. Just to touch upon how to manage these cyanotic spells, the first management of these cyanotic spells is medical. And I know all of you must be quite aware of the knee-chest position. So basically, either children do it themselves, a learning child, the moment slightly grown-up children, they'll squat, what is known as squatting in these children. Or if the mother pushes, mother also understands that the child draws up the knees and thighs, flexes the thighs to increase the SVR and decrease the cyanotic spell. But if they are brought to the ER or as a doctor, what you need to do is to give them oxygen, boluses of fluid at 10 ml per kg, morphine, IV beta blockers, soda bicarb infusion or correction of acidosis, ketamine infusion to sedate the baby, and in a worst case scenario, a ventilation. Very uncommonly, or sometimes these babies may require to go for some sort of surgery, either Beetle Shunt or a total correction as an emergency. So just to reiterate the point, all babies of tetralogy of fellow with cyanosis will require surgical repair. I just operated on a 16-year-old child whose parents knew from the very beginning that he had this disease, but he came and told me, the doctors told me he'll become okay, he'll become better as he grows up. So that's not the case. All patients will require surgical repair. If the patient is stable and minimally cyanosed, he's got his saturation on SpO2, on a finger probe is more than 85%, more than 80%, and he's not having any cyanotic spells, as I explained earlier, the total repair should be done at the age of 6 to 12 months. Weight is no longer a criteria. The earlier dictum of 10 kg, 10 months, does not hold true any longer. With the advance in cardiac surgery and the skills and the technology, along with the equipment we have, we operate babies as young as 10 to 15 days and do a total correction. My colleague here has just done one such case as an emergency. So age is not a criteria. Weight is not a criteria, but still we are looking at an ideal time when we should operate on these babies. So if the baby is stable and minimally cyanosed, then we say, okay, 6 to 12 months of age, any time between that, they can come up for elective surgery. But if a baby has had any incidence of a TED spell, I think he should be operated at the earliest. TED spell, the mother or the father will come and give a history of baby losing consciousness or having a seizure-like symptom or going limp all of a sudden. Generally, it's after a feed or an episode of crying or some fever or something. So these babies should be given the surgical option as soon as possible. Now, surgery in this very small infants and neonates depends on what is the expertise of that center, what is the expertise of the surgeon, and how well a center looks after neonates. It may not, every unit may not be able to look after these neonates after surgery. So in the symptomatic infants, we have multiple options, a few intervention options, a few surgical options. The intervention options which the cardiologist can carry on is a PDA stenting, a right ventricular outflow tract stenting, that's either put a stent between the aorta, a metallic stent between the aorta and the PA, so that the blood flow to the pulmonary arteries and hence to the lungs is good and the baby can go further up and have a surgery at the later date. The other one is the narrow right ventricular outflow tract. Now, they are able to put a stent in the outflow tract, and which increase the antegrade blood flow through the RVOT. And then the surgeon can electively operate that baby at a more comfortable time. The third option is the pulmonary valve is very small. So a balloon is crossed across the pulmonary valve and dilated. And the pulmonary valve balloon dilatation also offers them good palliation. If none of these things are available or the child is not fit for it, then the surgical options is a Beetle Shunt. A Beetle Shunt is also a Blalock Taussig Shunt. Both very famous pediatricians, one a pediatrician and one a surgeon, Helen Taussig and Blalock. And it's a surgical procedure in which a shunt is taken from the one of the arteries coming out from the aorta, and attached is a tube which is attached to the pulmonary artery. You can't see the pulmonary artery on this diagram. It seems to be going into the SVC, but here the pulmonary artery, so that the blood flow starts from here to the PA. There's a similar thing to doing a PDA stenting. Well, now, as I said, more and more centers are going towards total correction in one go, because why offer a child two procedures if one can sort out the problem for good? So there's a lower threshold for surgery early if no trans, means that we don't have to cut the pulmonary valve, what is known as the transannular patch, cutting through the pulmonary valve. It is not required, which is a decision which is made on the basis of the size of the pulmonary valve and its anatomy, jointly between the cardiac surgeon and the cardiologist. So if no transannular patch or tap is required, then we go earlier for surgery. If by any chance there are situations like of pulmonary atresia in which there's no pulmonary arterial connection to the right ventricle, basic anatomy, to the right ventricle, then the patient will require a tube or a conduit, which can be put only ideal to his present size because of the limitation of space in the chest cavity. So we try to do one of these procedures if a conduit is required, and then wait till the baby is 7 to 10 kgs to give him a larger size of conduit, which will last him longer, because sooner or later, all these conduits will require revision. Okay, that is all for tetralogy of Fallot, which you will see very, very frequently in your clinical practice. Now, the second important cyanotic condition is a transposition of great arteries, which is one of the complex subsets. Now, if you look at this diagram on the right, the blood comes to the heart from the SVC and the IVC to the right side. The right side pumps, basic anatomy of the heart. The right side pumps the blood into the right ventricle, from where it goes to the lungs. All right. Now, this blood comes back to us. That means to the left side of the heart through the pulmonary veins after oxygenation, and is pumped into the aorta. I hope you got this basic anatomy right. In a transposition, because of complexities of development of the heart and some aberration occurring at that time, the aorta arises from the right ventricle. You can see it on the diagram on the right. So the right ventricle pumps blue blood or deoxygenated blood in the aorta, and the left ventricle pumps oxygenated blood in the lungs. So this is what we call a parallel circuit. This is a parallel circuit which is occurring. There's not a continuous circuit like the normal heart. It's a parallel circuit which is formed, and the baby survives after birth only by way of a couple of things. One is the presence either of a PDA or a small ASD or a small VSD, because in this parallel circuit, blood has to mix at some place. And if no mixing is occurring, then the baby comes within a few hours of birth, the baby becomes extremely moribund and cannot survive. If the PDA is closed, or there's no ASD, or there's no EG, extremely blue, lethargic, tachypneic baby with very bad acidosis. So at birth, transposition of great arteries is the most common heart disease. It's 5% of all congenital heart disease, 2 to 3 per 10,000 live births, which is classified as simple TGA or complex TGA, which is simple TGA is no ventricular septal defect, complex TGA is with VSD, and the timing of surgery depends on the anatomy. So as I've explained to you, if it's a TGA with intact septum means there's no VSD, a small ASD which is keeping the baby alive, two things are occurring. One is there's no mixing of blood occurring between the two parallel circuits. The second thing, which is more dangerous, which is occurring, is the left ventricle. Because of this transposition, is pumping blood into the pulmonary artery, a low pressure circuit. So it forgets how to pump blood into the body, and that is what we call regress left ventricle. So the ideal timing for surgery in transposition the intact septum is 7 days to 3 weeks before the left ventricle starts regressing. Just don't concentrate on what is written lower down, it is not for you. But the TGA with intact ventricular septum, anywhere you read this report of an echo being done or there is suspicion, ideal age for surgery is 7 days to 3 weeks. Even if the baby is looking okay, please send him for surgery between 7 days and 3 weeks. A transposition with large PD and VSD can wait up to 6 weeks. And after 6 weeks, he starts getting pulmonary arterial hypertension. So this period is also very important. And a transposition with an obstruction to the flow in the left side. We have to wait a little later, but that discussion is beyond the scope of this lecture. And I think these are the last two common diseases which you will have a look at. This is again a very common diagnosis. Pediatricians and clinicians who run their own outpatients will see from time to time, which is known as TAPVD, TAPVC, or total anomalous pulmonary venous connection. So again, I'll try to explain it with this diagram. This is a normal heart in which all the pulmonary veins, after getting oxygenated blood, are opening into the left atrium. This is normal cardiac anatomy. In all sorts of TAPVCs, this connection of the pulmonary veins to the left atrium is not there. So these veins meet each other, form a common chamber, but they are not connected to the LA. LA is without any pulmonary veins. These veins drain either the right, on the right side of the heart through a vertical vein into the right atrium, which is known as supracardiac TAPVC, or go downwards and cause a common vein going through hepatic vein into the right atrium, which is known as the infracardiac TAPVC, or into the coronary sinus or directly into the right side of the heart, which is known as intracardiac TAPVC. So forgetting all these classifications, leave it to the cardiologist to decide or the surgeons to see the complexity. You just concentrate on the basic factor that these babies are draining the pulmonary blood flow after oxygenation to the right side of the heart and not to the left side of the heart. So how is the blood going? The blood goes to the right side of the heart only through a small ASD, left side of the heart, and then it goes to the lungs. So there's mixing. There's a cyanotic heart disease, and the ASD might be small and it may become obstructed. So this is about 1% of patients born with congenital heart defects. All these patients require surgical repair. Non-obstructed will not present to you as an emergency. They will present as a routine checkup. Sometimes we get patients with TAPVC who are as old as in their early 20s. So these patients should be operated as and when diagnosed as early as possible. But an obstructed TAPVC is an emergency. Obstructed TAPVC baby will present to you in lethargy, very tachypneic, may require intubation, severe acidosis, severe lactemia, and very, very low cardiac output. And these babies need to reach a cardiac surgical center as early as possible because there is no other option of saving these babies. So I'll try and finish my talk here because, further than this, there are very few things in cardiac surgery even I understand. And if, as Albert Einstein said, if you don't really understand something unless you try and explain it to your grandmother. So if I don't understand it well enough, after so many years of practice, I don't think is the right thing for me to load you with it. But these basic 5, 7, 10 diseases which I've told you about are the ones which you're going to see from time to time. And if you get an understanding of when to send these patients for surgery, you will probably cover 95% of critical congenital heart disease, which should be treated at the right time. So thanks very much for your attention. And thanks once again to the academic team of SRCC for allowing me to take this talk. I'll be very happy to take any questions now.
Yeah, thank you very much, sir, for this wonderful lucid explanation regarding the things. We have a couple of questions we would like to take.
Yeah, sure.
So the first question is, so that is asking about role or mechanism of medication on small PDA. That is from Dr. Mulchan Talreja.
Yeah, Dr. Leja. So a small PDA, see, again, as I said, if they are symptomatic babies, a small PDA, again, we define PDAs on the basis of whether the baby is symptomatic or not symptomatic. If the baby has features of congestive cardiac failure and the baby is very small, then it's most likely a large PDA, and we can put the baby on some diuretics and afterload reduction like Envas, some Furoped for a little while, and if the baby improves, this I'm talking about term baby. If the baby improves, then it's okay. You can send them for surgery or intervention at some reasonable stage. But an echo, of course, is important because if the left heart dimensions are large, probably the baby, even stable on medication, might require intervention of some kind. I'm not talking about preterm babies in NICUs with PDA because these babies have different subset. They may close spontaneously over a period of time or close with NSH. They might close with NSH, and that's a different subset. But even in NICU, if a baby does not respond to NSH therapy or for closure and has congestive cardiac failure, is ventilated, and we are not able to extubate, sometimes when very small birth weight babies, we might have to surgically close the baby because intervention is not possible in these cases. I've operated in some peripheral NICU babies as low as 700 grams on the bedside. So yes, I hope that answers your question.
Yeah. One more question. Does hereditary have a role in congenital heart disease?
Yes, not in all, but yes, there is definite incidence in tetralogy. Nobody knows why, but 10% cases of tetralogy parents may have children with tetralogy of Fallot, and there's a similar incidence in siblings in tetralogy. Not all congenital heart disease, but yes, there is. Nobody knows why or how. I mean, there's no defined, as far as I know, there's no defined sort of genetic anomaly in the parents which may cause congenital heart disease. But yes, there is a definite hereditary relationship. The others, of course, maternal conditions like rubella, maternal conditions like SLE have a high incidence of congenital heart disease.
Okay. Yeah, thank you, sir. You would like to highlight that what are the facilities available at our SRCC regarding cardiac surgery is concerned?
Well, SRCC, we are the tertiary care centers, one of the busiest centers in Mumbai and Maharashtra as far as congenital heart surgery is concerned. So we have a thriving unit. We have 3 surgeons, 3 cardiologists, very accomplished cardiologists and fairly senior surgeons. We have 26 bedded ICU. We have all kinds of supports like ECMO, left ventricular support devices, and all complexity of cases from preterm babies to few-day-old neonates to adult congenital heart surgery is being conducted here. We have a thriving radiology department which helps us making very complex diagnosis very simple for us. We have a very high-end cath lab where our cardiologists carry out all the complex procedures, and our intensive care is top of the line, probably one of the top intensive care group which I've seen, including abroad. And survival after complex congenital heart disease ranges between 97 to 98%. So yes, we are there as far as congenital heart surgery support and congenital cardiology, pediatric cardiology support is required within the city, state, or in the region.
Okay, great. Thanks. Anybody have any question? You can directly ask, sir. Is available for next 5 minutes or so. You can ask any simple doubt or. Yeah, I guess.
All right.
Yeah.
Thanks everybody. Thanks for your hearing. Thank you very much, Irene, Dr. Rasek, for inviting me for this lecture. Thank you.
Thank you once again, sir, for enlightening us. See you next time. Thank you.
Thanks.
Yep. So now moving ahead, we can go to the next speaker. So our next speaker for the next talk is Dr. Manish Shah, and he is a senior consultant in Paediatric Dermatology department at SRCC Children's Hospital. He is affiliated to other hospitals as well, and he's a renowned dermatologist with vast experience of last 15 years, and he's specialized in phototherapy, acne, pigmentary disorders. He has organized various national and international conferences. He has been an observer at University of Texas Health Science Center at the San Antonio, and he has done his study on keloids and response to treatment with retinoids. I think recently he has written a book on dermatology in which he has got a very great response by the readers, and he's always actively involved in the academics by organizing this kind of academic related information. So without much wasting time, I would like to invite Dr. Manish Shah to present his topic.
Thank you very much, Hirenbhai. I think Gaurav, Mr. Dr. Kumar's screen is still being shared. I'll be able to share my screen.
Are you able to share?
Let me see.
Yeah.
I think so. Yeah.
Yeah.
Okay.
Yeah. We can see you. We can see your slide.
Okay.
Perfect.
Yeah. Thank you very much for those kind words. Yeah, actually, I'll be finishing 30 years of practice right now.
Oh, wow.
And it has been a great journey. And when I was asked to take this talk, I thought, there are pediatric dermatology, there are common conditions, and there are certain conditions which sometimes a non-dermatologist would not know of, but which are important in various ways, diagnostically, therapeutically, and the outcome can change drastically. And I'm going to present some common and some not so common cases, but each of the cases has a message. And I hope all of you will enjoy and gain something out of these cases. So I'll start with case number 1. So there was this 15-month-old male child who had come with these lines, these dramatic lines at various places in the body. There was no itching. There was no history of any itching at all or any systemic complaints. And there was no history of any systemic medications, which could have contributed in any way. Again, you see these bizarre linear lesions, dark lesions, and more. Again, you see these lesions here. It's as if they've been produced, but parents are quite categoric that child is not itching at all. See these lesions here. So, and more. So this is just, it was kind of very surprising as to what's going on. Why these kind of bizarre linear lesions? So these are, like almost like certain areas like whiplashes, as if, they like you flagellate yourself in Morum, like that these lesions are. So one clue that we derived, the patients had not said, but we saw these lesions and we asked, what was done? And then the patient said, yeah, this lesion was there since almost shortly after birth, and some injection was taken. So obviously this is a parotid hemangioma. This is a close-up of that hemangioma. And pediatric surgeons had given intralesional bleomycin for this. So we all know that bleomycin systemically can produce flagellate erythema as well as flagellate pigmentation. So here we just reassured the parents and told them that this will subside, and the lesion subsided. And we informed the surgeons that this is happening, and so things were fine. But we did inform them that this possibility is there, but after that, still after 2-3 weeks, there were no options were limited, and they wanted to give it another trial, and they did it again. And the next time there was again a more exaggerated response of this kind, which took almost 3 weeks to resolve. After that, of course, bleomycin was not administered. So it's been quite commonly known in literature that you can get flagellate pigmentation following systemic bleomycin. This is again a bigger view of the same picture in the published article. And of course, in the dermatology literature also, there are reports of flagellate hyperpigmentation after intralesional injection of bleomycin, here for lymphatic malformation, cystic hygroma. So when malformations are injected bleomycin, there is a risk of systemic absorption and getting a flagellate hyperpigmentation. This is just important to know so that you don't think of other things. So this is not uncommon. Bleomycin-induced flagellate pigmentation can happen within a day to 9 weeks after bleo. It does reverse once the drug is discontinued. Of course, it can recur with greater intensity whenever it is re-administered. And then you have these bizarre linear lesions in this child who was brought with low-grade fever and severe muscle pain. Very pruritic. Here, not only pigmentation, but you can see some of this violaceous red streaks all across. This is provided by my friend Dr. Sandeepan Daur from Kolkata. So this is again a very dramatic form of linear lesions, some of them erythematous, some of them pigmented, in association with low-grade fever and muscle pain. So this is a very rare presentation of dermatomyositis. So zebra-like erythema and pigmentation that can be seen in dermatomyositis. So whenever you see some dramatic linear lesions, these couple of things one can bear in mind. So this is a very early case report of flagellate erythema in a case of dermatomyositis. So most of these erythematous conditions in our skin present more with pigmentary changes. So the take-home message from these couple of cases that keep in mind that pediatric surgeons are injecting a lot of intralesional biomass, and if you see these flagellate pigmentation, one must just recognize it. And very rarely dermatomyositis can present with flagellate or zebra-like pigmentation. Coming to case 2. So this, I was called to the NICU for this baby, and basically low birth weight, failure to thrive, and these dramatic lesions. So you have these erythematous lesions, a lot of telangiectasia are studied on it, and then you have here patches which are annular, ring-like. Some of them are hypopigmented. So this constellation of findings in a neonate with low birth weight and failure to thrive. Along with it, there was a pancytopenia and increased serum transaminases. Another picture again. So this is the kind of findings that you are getting. So this is again on the back, where you have more of hypopigmentation, some amount of atrophy in these lesions. So again, erythema on the face, periocularly, lot of telangiectasia, psoriasis-like lesions at places, and hypopigmented annular lesions. So this is a presentation of neonatal LE. So this child, I just told them to get an anti-ROA and anti-LA done. Both were positive. Mother's anti-ROA and anti-LA were positive. So this was a neonatal lupus erythematosus. And these are the ways in which lupus erythematosus can present. This child had quite a few of these lesions in one child. Otherwise, you don't see all of them in a single child. Then we have had, in the last 2 years, we have had at least 5 cases. This is another case which initially was thought by a resident to be kind of an irritant dermatitis. This almost linear-like dermatitis. But here again, there is some amount of erythema, some amount of purpuric element to this. And there was this child again with annular lesions, ring-like lesions, central hypopigmentation and atrophy. If you see an infant or a neonate, of course, this will be more, this neonatal lupus erythematosus presents typically before 3 months of age. So if you see a neonate with erythematous or telangiectatic lesions, or if you see annular lesions with atrophy, see annular lesions you can get with ringworm, but they will not have central atrophy. If you see atrophy, do think of neonatal LE. It's very important to pick up neonatal LE. Obviously, anti-Rho and anti-La antibodies are quite specific and are usually raised. The significance is that a significant proportion can have heart blocks ranging from first degree to second degree to complete heart block, and early recognition can save the life. Okay. The skin lesions are nothing to worry about. They are self-limiting. They usually don't even need treatment, but this helps you to diagnose something else within. And another very important thing is that the mother sometimes may be asymptomatic, but may go on to develop a full-fledged collagen vascular disease in the future also. So not only it's important to investigate the child, but it's important to follow up the mother long-term. So this is neonatal LE. Case 3. So this child came, again, this was an infant, came to a friend of mine at Thane, and basically low-grade fever, irritability, basically failure. There was some amount of these systemic viral manifestations, and there was these fluid-filled blisters, huge, large blisters on both the limbs. And this was a case of infantile chikungunya. So the mother had, again, IgM positive for chikungunya, and the child also was IgM positive for chikungunya. And basically it was observation and symptomatic treatment, and this resolved. But again, it was important to recognize this. Otherwise, one would think of autoimmune bullous diseases, etc. So here there were febrile manifestations, and the mother had fever and joint pains. And do remember that it's only in infants that you'll get these bullous lesions. Adults get more of a maculopapular rash or pigmented lesions. Only in children, basically in infants, do you get these vesicular lesions on the limbs. So severe bullous lesions can be associated with chikungunya in infants. This was a child who had fever, severe myalgia, vomiting, pharyngitis, and these blotchy lesions, which were erythematous here, and here you see slightly pigmented. Some amount of chylitis happening, and these erythematous, blotchy, linear lesions. Again, right now they are more erythematous, but at certain areas you can see the onset of pigmentation, and you can see the reticular lesions here. So this presentation is again typical of chikungunya. This was again typical chikungunya. Now these we need to recognize, because chikungunya is not uncommon, it's quite common. So we do see chikungunya from time to time. And this is one thing which you don't even need to do a serology. There are some striking pigmentation that chikungunya produces, which is pathognomonic. This particular thing where you get striking hyperpigmentation on the face, especially on the nose, this is called chick sign. So this is very typical of chikungunya. Other than that, you can get linear presentation, linear lesions like this, hyperpigmented linear lesions. This is again chikungunya. And this was a dramatic presentation. Basically, infant brought with low-grade fever, minimal toxicity, and the skin coming off in sheets, starting off as vesicles and bullae like this, and then coming off in sheets. This is very typical. This coming off in sheets is typically, as you would be aware, seen only in two conditions: staphylococcal scalded skin syndrome and toxic epidermal necrolysis. Okay, so SSSS is comparatively more superficial. You don't get these deep, it's more superficial exfoliation in the stratum corneum level and typically around the orifices. This presentation that you get of deep epidermis coming off in necrotic sheets is typical of toxic epidermal necrolysis. There was no history of any drug ingestion, and there was no mucosal involvement here. So this was a very strange thing. Again, here it was found out that the mother too was sick and had arthralgia and tested positive for chikungunya. So this was a toxic epidermal necrolysis presentation of chikungunya. So chikungunya can present as TEN-like lesions, but without the severe toxicity. As if you would have seen Steven Johnson and toxic epidermal necrosis, you can see how sick the child is. This child was not that sick that way, and more importantly, there was no mucosal involvement. Typically, in toxic epidermal necrolysis, you will see mucosal. SGS10, you will see mucosal involvement. So here, nothing was done, just observation and local care, and within a week, things had healed with some amount of dyspigmentation, which even gradually cleared off. This case was presented, was shared by Dr. Arul Inamdar from Bijapur. So some pearls on chikungunya. Of course, we know apart from the maculopapular rash, which may be non-specific, linear or blotchy pigmentation is very typical. Blotchy hyperpigmentation of face, limbs, nose is typical of chikungunya. In infants, you can get bullae on the distal extremities, and it can rarely present with SGS, a 10-like presentation, with not much toxicity and no mucosal involvement. So there's some pearls of chikungunya. Case number 4. So this infant was brought with these smooth nodular lesions on the toes. Okay, firm nodules, and not only on the toes, but see the close-up, head-on view, and also on here at the side of the digits. So the conventional wisdom would be that one has to at least get a biopsy, and one may need to excise this. But this is an entity that we are seeing in the last few years called infantile digital fibromatosis. Okay, so this is something which is seen in infancy, and the beauty is that by 2-3 years it goes on its own. So it would be actually counterproductive to do any kind of invasive procedure. You do not need a biopsy usually, and excision, apart from leaving a very bad scarring, may be followed by a recurrence for a condition which is anyway going to go away, and eventually it's going to go away anyway. So one just needs to recognize this entity. So just to show you again, firm nodules on the digits and in the side of the digits in infants. Next case. So this was an infant who had been given by a lot of pediatricians a whole lot of creams that included some barrier creams, zinc oxide based creams, steroid antifungal creams, but there was no response, and it was extremely uncomfortable. The child used to cry every time there was used to pass stools. It was very uncomfortable situation. So this is something which everyone needs to recognize. You can see a erythema which is circumferential and well defined, as compared to sometimes in a napkin dermatitis or a perianal dermatitis, which is usually not very well defined. Here you get these very well defined lesions, And here there are these erosions also in between. So this is an entity called perianal streptococcal dermatitis. Now they call it perianal infectious dermatitis because even staph can produce perianal dermatitis. So what causes this dermatitis is actually a streptococcal sore throat that would have happened earlier, and it's a toxin, the streptococcal toxin, that produces this reaction. So this is perianal infectious dermatitis or streptococcal dermatitis, presenting as sharply demarcated circumferential erythema in the perianal region, with sometimes vesicular pustular lesions and erosions in that area. There may be blood streaked stools, there may be some amount of crusting there. And of course, you can confirm the diagnosis by culture. And treatment is not only topical, but oral antibiotics. Oral first generation cephalosporins along with topical mupirocin or fusidic acid ointment. Here, this was actually presented as a kind of a severe insect bite reaction, followed by these lesions. This is a kind of an emergency situation. Started off with that, but later on went on to become secondarily infected. A lot of extremely tender, extremely painful erythema, bullous lesions, cyanotic lesions, and then now necrosis, severe necrosis. So this is a condition called necrotizing fasciitis. This can be life-threatening. So this requires aggressive management. Other than you need to give a broad spectrum antibiotic plan combination, which will include gram-positive, gram-negative. You may have to cover for MRSA, you will have to cover for Pseudomonas, and sometimes even anaerobes. So it's a kind of a multi-bacterial. You can't wait for the culture reports. You have to start treatment empirically here. And the most important thing is urgent surgical referral, and all the necrotic tissue needs to be removed as fast as possible. Okay. So this is very important to recognize. Necrotizing fasciitis. Then there was this 5-week-old child with acute onset of these large red lesions on the body that happened shortly after fever. So you have these erythematous, slightly edematous lesions of bizarre shapes. So some of this just looks like urticaria. But here you have these large ring-like lesions. And again, you have these annular lesions. Somewhere the rings are not completely round. So here you have, again, a lot of erythema, annular erythema. And here you have these targetoid lesions. Looks like almost like iris lesions, erythema multiforme-like lesions. So this is something which is important. We do see it in practice quite often. And we need to be able to recognize and treat it. The most important thing is that when you see these kind of lesions and you presume it to be like erythema multiforme or something, please do not give steroids for this condition, because this is a condition. Again, I'll show you more pictures. Again, large erythematous, edematous annular lesions, some of them erythema multiforme-like lesions. Usually there is some amount of edema of the limbs associated. Erythematous, edematous lesions. Okay. This is a condition called giant annular urticaria of children, and also called as Urticaria Multiforme, because it has features of both urticaria and erythema multiforme. So basically, it's a benign cutaneous sensitivity reaction, mainly occurs in children, can occur following any febrile illness, whether a viral or bacterial infection. It can occur following certain drugs or vaccinations also. Basically, it is a pleuritic condition which looks very much like urticaria, but looks a bit atypical. Edema of the limbs often is present. Like in urticaria, if you see very carefully, individual lesion does not last for more than 24 hours. But most parents will not be aware that they'll say that the lesions are not going only because there are multiple lesions, new lesions coming and old ones going, and you can't keep track. Even in urticaria, sometimes the patients will tell you that each lesion is lasting for more than 24 hours. And the whole outlook changes. When you have individual wheals lasting for more than 24 hours, your diagnosis goes towards urticarial vasculitis and collagen vascular diseases. So your whole outlook becomes different. So in that situation, it's sometimes good idea to just mark out one lesion and observe that area after 24 hours and see whether it remains or not. That gives you an idea whether the individual lesion is actually lasting for more than 24 hours. This condition clears off within a week, anything between 5 to 10 days. And it's very well responsive to H1 antihistamine, just like urticaria. So even though it looks dramatic, although it looks like EM-like lesions, it responds very well to antihistamines. All you need to do is treat the underlying fever. That's all. The rash goes away. Okay. Coming to next case. So this is a 4-year-old girl who was brought with this growth since birth. Take a good look at this. Closer look. So what would you like to do here? Which of these options? Since this is interactive, now I'll try and see. We'll give a minute to see what how people would approach this. I encourage you to give me your thoughts how you would treat this child. Okay, propranolol. Option B, pulse dilator. Okay, a very specific treatment for hemangioma. Then, acha, this is important. Show the picture again. Correct. Okay, so now this is a kind of a trick question. This actually is a vascular lesion that is obvious, but it's present since birth and almost been the same size since birth. And there is a difference in the limb girth, if you compare the two limbs. Okay, so turns out that actual answer should be none of the above, because this is not an infantile hemangioma. This is a different thing. So how do you differentiate an infantile hemangioma from other vascular lesions? This is what is important. So actually an infantile hemangioma, if you take a careful history, is usually either not present at birth or present as a very small precursor lesion. It actually develops in at around the first 4 to 6 weeks of life, slightly more common in premature. Then there is an exponential growth phase. Over the next few weeks, it grows rapidly. So by 6 to 9 months, it's growing rapidly. And then after 1 to 1.5 years of age, it starts growing into the involution phase, which lasts up to 4 to 6 to 8 years of age. And then there's a small, very small residual lesion or sometimes no lesion present. So this is a typical course that an infantile hemangioma follows. But how do you differentiate an infantile hemangioma from something called a congenital hemangioma or a vascular malformation? So as compared to infantile hemangioma, which I told you, congenital hemangiomas, of course, different types, but they are present since birth. They are present fully developed since birth. They may be two types, rich, which is the rapidly involuting congenital hemangioma, or the non-involuting congenital hemangioma. And then there are these couple of congenital hemangiomas which are complex lesions, either called the histopathologically, they are identified as either tufted angioma or caposiform hemangioendothelioma. These couple of things, these are the dangerous ones, because it's in these two conditions that you get these Kasabach-Merritt syndrome, the consumption coagulopathy, which can be fatal. This Kasabach-Merritt does not happen in these congenital hemangiomas, and it does never happen in infantile hemangioma. So this is important to know. And then you have a whole lot of vascular malformations, which are congenital ectatic dilatations of various vessels that are present since birth, that remain the same, do not increase rapidly, nor do they regress. They remain more or less the same. They may increase a bit when there is infection in size. So here the growth pattern is infantile hemangioma. I mentioned you the growth pattern. In rich, it starts like a infantile hemangioma. It tends to regress quite a lot within the next 3 months. And non-involuting obviously remains the same and may increase in size with infections. And all these vascular malformations steadily just increase with the rest of the body. So this is a picture from a journal of a case of rich. It's a congenital hemangioma. This was present since birth, but within a few weeks it became like this without any intervention. This is a rich, rapidly involuting congenital hemangioma. So what we had was, eventually we confirmed that it was actually a vascular malformation. It was an arteriovenous vascular malformation. And the management of this is first to embolize. So here, this is where Dr. Hiren Panwala and our other radiologists, especially interventional radiologists, will selectively embolize the feeding vessel, arteriole, and then once it is shrunk, the lesion has to be excised, if amenable to excision. So here, in these conditions, propranolol does not work. So propranolol does not work in all vascular malformations. It works only specifically in infantile hemangiomas. And flash lamp pulse dye laser is also effective in any vascular malformation, and in infantile hemangiomas primarily, or smaller capillary malformations like the port wine stains. It works well, but for malformations it will not do much. Then we had this this was presented, was actually referred by a friend of mine to us in Wadia. And this again, at birth, this was not present. Within the next 4 to 6 weeks, you got this large lesion which covering half the face. And here you can see some amount of erosions here. So this was an infantile hemangioma in a segmental distribution. When you have a large infantile hemangioma on the face in a segmental distribution, one has to think of and rule out whether it is a part and parcel of something called as face syndrome. Hemangioma with posterior fossa malformation, H is hemangioma, A is arterial abnormalities, C is cardiac abnormalities and coarctation of aorta, and I is eye involvement. So in this child, there was eye involvement and there was Dandy-Walker malformation of the brain. And this, in this situation, again, the management is carefully giving propranolol, because the concern is when there are malformations in the brain going on, the propranolol may potentially decrease the blood flow and make the child prone to thromboses. So, but we have managed 3 cases of face syndrome after admitting them, giving them propranolol. So in this particular child, this was how the child presented. We admitted the child. By a week, this was the response. By a month, this is the kind of change. And by 4 months, see the dramatic difference. What is this and what this is? So parents were over the moon with the outcome. And of course, the child has been following up with us, and no other developmental abnormality, nothing at all. Child did very well. So we have this child who has these lesions here that from time to time ooze a bit, and sometimes there is blood tinged discharge. What to do next? I'll wait for your replies. There have been some questions, we'll discuss them. I'm going to just discuss for another 10-15 minutes, then we'll take up question answers. Any thoughts how to progress with this? First of all, what is the diagnosis? Let's have the diagnosis. Okay, that's one thought. Okay, so the thing is, why it is not a wart is because obviously there are these vesicular lesions, and sometimes you may get hemolymphangioma, some bloody component also. So this is again, warts and molluscum look like this, but if you see, sometimes you may just puncture one and see what happens. If you see a clear colored fluid or a blood tinged fluid coming out, then obviously it is not wart or molluscum. These grouped vesicular spawn-like lesions are lymphangioma circumscriptum, or basically this is a kind of a microcystic lymphatic malformation. Now, the typical thing what one often does is one does destructive modalities. So one may often do a cautery or laser ablation or cryotherapy, but they all recur because this is a manifestation of a deep plexus underneath this. So there have been attempts made to, by MRI, delineate the depth of this and excise the whole thing in toto, but still it recurs. So you can obviously see the surgical scar here. Obviously this child has already been subjected to attempt to remove the lymphatic malformation. So lymphatic malformations should better be left alone. They should not be excised. It's impossible to try and often you will end up with a worse situation. And once it recurs, it is quite traumatic to have a terrible scar, and sometimes the healing also may not be that great. So lymphatic malformations, recognize and try and avoid surgery. Now, how do we deal with this? So a new modality in the last couple of years that has come up for this is rapamycin or sirolimus, which is a mTOR inhibitor. So what this does is it shrinks these tumors which express RAS protein. And this rapamycin actually is not available as an ointment, it's available as 1 milligram tablets. But you can compound them. You can ask the pharmacist to prepare 1% rapamycin. And after applying topical rapamycin, there was this paper published in that evaluated almost more than 80 children in whom rapamycin had been given for lymphangioma circumscriptum. And they tried two concentrations, the 1% concentration that we use, but they used a lower concentration also, basically to save cost. Because this 1 milligram tablet costs almost 50, and even if you get it from the company, it costs 50 rupees or so. So just a 10-gram tube will cost you 5,000 rupees. So a lower concentration can be tried later on as maintenance therapy. They did, it's actually supposed to be applied twice a day, but once a day also is not bad. And what you find is the surface area reduces, the dark discoloration reduces, the number of vesicle volume decreases, and symptomatically also there is a lot of relief. Improvement usually starts in 2 to 4 weeks. Irritation can happen, and that may have to be managed by decreasing the frequency, making it once in 2-3 days, etc. But usually irritation is well tolerated because the improvement in the lymphangioma is drastic. Maintenance treatment 2 to 3 times a week may be required because you cannot change the malformation. You stop the treatment, the malformation is going to remain. No medication is going to remove the underlying abnormality of the blood vessel, of the lymphatics. So this is, we have used it in quite a few of our patients. This is just one patient who had these recurrent episodes of fever and these painful tender lesions, which were oozing all the time. And by 4 months, this is the outcome. So you can see it has not gone away, but they have shrunk and they're not as inflamed as before. Okay. Then we have, okay, I have good time. I have another 10-15 minutes before we discuss. I'm going to just discuss 2 more cases and then we'll go to discussion. So there was this child who presented, sorry, what's the diagnosis? Someone spoke something. Okay. So there is this painful lesion in the oral cavity, which happen recurrently. So this girl has these painful oral ulceration, which practically once in a month or once in a two months happens in different parts of the mouth, each episode lasting 5 to 10 days. And this happens more at sites of trauma. So first, what is this and how to deal with this? Wow. This person is good, huh? Anything else? Someone has mentioned Jay is mentioned by someone has mentioned lichen. Okay. So basically, lichen planus presents more with papular lesions in the mouth, which have a kind of a lacy network. Sometimes you can get eroded lesions, but that lichen planus never completely goes away. It just keeps on happening again and again, and it's a severely painful condition. But here I have mentioned that these painful ulcerations goes away. Each episode lasts 5 to 10 days, goes away, and then comes back. So then it comes to what has been mentioned. Someone has said Bessette Syndrome. So Bessette Syndrome is occurrence of these painful lesions along with often similar lesions in the genitals, usually in males, and in the eye. So usually combination of 2 or 3 mucosal involvement. So here this is only oral mucosal involvement. But this condition that I have talked about is very in the same group as Bessette syndrome, but this is much more common. Bessette is a rarer disease. This is something which is much more common. Only thing, this is bigger. Smaller lesions like this you see often in practice. So this is just aphthous ulceration. This is aphthous ulceration. Adults can get it, children can get it, and it can happen. A whole lot of things contribute to this, but primarily friction and trauma triggers it off, and it is basically something to do with your immune system that is responsible for this. From time to time it happens. In adults, stress can trigger off aphthous ulcers, but of course there are a lot of other triggers of for aphthous also. So how do we treat aphthous ulcerations? Individual episodes, one can just apply a bit of topical steroid, triamcinolone acetonide in aura base applied on the lesion, and within a few days, it will settle a bit faster than it would do otherwise. But what about this recurrent aphthous ulceration? So recurrent aphthous ulceration, whether it is just recurrent aphthous standalone or recurrent aphthous in Bessette syndrome, both these respond very well to oral colchicine. So this in children, if you give 0.5 milligram once a day to begin with, and in older children, you can increase the dose, or you can even give 0.25 milligram depending on their age. Oral colchicine is extremely safe. Only in the initial 3 months, it is good to do a blood count once a month, because rarely bone marrow toxicity can happen. But otherwise, as you would know, in familial Mediterranean fever, oral colchicine prophylaxis is lifetime, and it prevents a lot of the complications, including systemic amyloidosis and deafness in those situations. So colchicine can be given lifetime. Here in aphthous ulceration, typically you don't need to give it for more than 6 months. So this child, after starting colchicine, stopped getting those recurrent aphthous for the next 6 months when she was on colchicine prophylaxis, did very well. So this is a clue worth keeping in mind, that if you have isolated episodes of aphtha, you can just treat it symptomatically. Sometimes severe aphtha, you may just give a 5-7 day course of oral steroids. But for recurrent aphthous ulceration, oral colchicine is wonderful as a prophylaxis. Okay. And then I had this. This case we had at Bhatia, and this child used to get admitted repeatedly for these recurrent painful oral lesions along with pharyngitis and fever, and they used to get admitted because it was very painful. Child used to get toxic, and basically it was presumed to be possibly herpes simplex, and the IgG antibodies were marginally high. And of course, one of the other things there was the counts were low. So what could this be? Right, this was what it was presumed to be. But if you see one thing here, the blood count is 3,400 and the absolute neutrophil count is 329. So it is very well known that neutropenia can cause aphthous-like ulcers. Okay, so there is a condition. Again, this is not common. This is not common. This is a rare condition, but worth recognizing. So this is a condition where there is a change whereby there are huge oscillations in the counts of the WBCs and the monocytes, where they intermittently dip to extremely low levels. And when they dip to these low levels, you get a trigger of infection, fever, sore throat, aphthous-like ulcers. And it can be, again, this can be a fatal condition. There's a condition called cyclic neutropenia. Earlier, there was not much treatment for this, but within the last few years, the hemat team manages this with GCSF. So granulocyte colony stimulating factor 1 to 5 microgram per kg, either daily or alternate day. It's an expensive treatment, but it changes the life. So this, once you started this, those oscillations come down and the huge spikes come down. The counts remain on the lower level, but they do not go, the nadir is not so deep. So, and practically this child, when started on GCSF, stopped getting these oscillations. Things became all right. The only problem is the parents were had their anxieties about this, so they did not take the GCSF regularly. They were taking low doses. Even cost was a factor, and they stopped the medicine. And unfortunately, after they stopped it, in a month, we lost the child. So cyclic neutropenia, rare condition, can be recognized. Aphthous ulcers that occur periodically associated with fever. And if you see do a CBC, if you see neutropenia, you can diagnose this. And last one. This was, again, this is a very sick child. In NICU, in shock, no skin, basically, there was no fever, but the child had these, was very sick, and these, a bit of this swelling of the limbs, a bit of acrocyanosis, and these lesions here. Okay. So now what you can see here are these, apart from the limbs being acrocyanous and some amount of edema, you have these, this is almost a reticulate or a star-like, a stellate pattern of purpura, along with these hemorrhagic bullae within this. So this is the condition called, shall we ask? Okay. So Kawasaki has more of these erythematous lesions. these are purpuric lesions, and in Kawasaki, you have erythematous lesions on the limbs. Then you have strawberry tongue. Then you have oral changes. Then you have a conjunctivitis, and then you have sometimes the lymphadenopathy. There will be thrombocytosis. But here there are purpuric lesions in a sick child, and in that previous one there was purpura which was stellate shaped. Here in this is a congenital variety of the same thing. Here you have geographic lesions of purpura and a rim of redness around it. So this is again a potentially severe condition. This is called purpura fulminans, and this will require intensive care, IV antibiotics, and one of these three options, purpura fulminans. Which of these? I'll save time and tell you. The treatment is to administer. Earlier, one used to think of giving heparin or oral heparin, but heparin was associated with, on the contrary. So what happens here is all this is a kind of a disseminated intravascular coagulation. It's a kind of a consumption coagulopathy. So if you'll do fibrinogen, FDP, D-dimer levels, they will be all high. Okay. And obviously there'll be the prothrombin time, everything will be prolonged. So here what you need to give is a fresh frozen plasma, because primarily it is a protein C or protein S deficiency. The earlier patient that I showed you was basically a septicemia induced, infection induced purpura fulminans. So this we had to treat the septicemia and then administer fresh frozen plasma. This was a factor C deficiency. So this child ideally would require anticoagulation for life after initially controlling the condition, or ideally protein C concentrate, which is extremely expensive. So this is important to recognize this condition called purpura fulminans, because again, unless you give the proper treatment, this can be life-threatening. So I think I'll conclude the cases here. And typically after purpura fulminans, those necrotic things crust like this and shed off, and then leave it's like a amputation. These all things, necrotic things sheds off. Sometimes you have to surgically excise them, and then you're going to be left with a scar. I'm going to stop sharing, and I'll be happy to take questions. I hope I was not too hi-fi, but although some of these cases may not be common, but it is extremely important to pick them up in practice. From time to time, if you see it, not only are you changing the life of the patient, of the child, etc., it is a challenge when you diagnose some rare condition. You get a high.
We all got high, sir, after listening to your lecture. It was simply amazing, sir. I have not seen this much of spectrum within a short time. You have done an excellent job. Being radiologist also, I could feel that, okay, this is something I can understand and I can apply when I'm seeing the baby or I'm doing some USG. I can have some insight or something. I would like to learn more from you from now onwards, and I might be troubling you more and more again in future.
Anytime.
Yeah, but this was like one of the best lecture I have ever heard in the dermatology topic. So we have got some questions like, so yeah, we'll start with from the top. So Dr. Ravindra Pajai, he had question that if infantile digital fibromatosis does not resolve after 2-3 years, what will be the line of management?
If it doesn't resolve, then of course, then surgical excision may have to be done. That of course, but usually it does. But I mean, ultimately, if it doesn't, then there's no other option, or you have to live with the condition.
Okay. And one more question. One second. Yeah, again, Dr. Ravindra Pajai was asking about, can oral histaminic be given in Urticaria Multiforme?
Oral antihistamine is the treatment for Urticaria Multiforme. Like the treatment of Urticaria Multiforme is the same as treatment of acute urticaria. Only thing is, do not give steroids. Just give antihistamines round the clock.
Okay. I'm just scrolling. So in between, during our discussion, Dr. Sabita Nayak was asking that how long colchicine can be given.
So as I had mentioned, in aphthous ulceration, we usually give it for 6 months. In a condition like Bessette, you may give it probably for a year or so. But in certain conditions, is auto-inflammatory syndromes like familial Mediterranean fever, etc. It has been given lifelong safely. So long-term treatment is not usually a concern. Colchicine is a very safe drug. So we just have to be, lose our anxieties about that.
Okay. Dr. Jai is asking colchicine for RAU in adults.
Absolutely. Absolutely. Treatment of choice in adults as well. As a matter of fact, in adults, we have given it all the more because aphthous ulceration in children is not as common as in adults. Adults, so it's fairly common. So if it is, again, let me stress on one thing, that you will not give it for an isolated episode of an aphthous ulcer. From time to time, aphthous ulcers even I have got. So that doesn't mean. This is for people who have recurrent RAU, recurrent aphthous ulceration, repeated aphthous ulcers. So this is more of a prophylactic therapy, not the immediate therapeutic modality.
Okay. I wanted to ask for one question.
Yes.
So basically, when we many times gets a request for some sort of skin or those kind of lesions, is there any good article or some reading material that we can apply as a radiologist that, okay, this will fit more towards like I can collaborate my imaging finding with your that dermatological appearance? Are those any articles regarding that or something like that which can help?
The best, so I think unfortunately dermatology can be very simple and can be complex depending on how your understanding of the subject is.
Correct.
It is a good idea to basically, first of all, understand primary and secondary lesionology, how to read the skin, like how you read radiology. You need to read the skin. So you need to understand what is primary lesions, it's not that appearance alone. Sometimes now you, as a matter of fact, someone told me that now that you have written a textbook, why don't you make an app whereby you can just apply an algorithm and artificial intelligence wise, you can just pick up these conditions. Unfortunately, it doesn't work like that. So diagnosis of skin conditions is multiple conditions may look similar. So here you require to evaluate the whole thing in totality, and you have to even take correlation of the other clinical findings. But it is a good idea to read a lot of atlases. So you become visually literate. So you can go through, I mean, my textbook, of course, has a lot of good pictures. I'm sure, I think I'll be giving one copy to the library. So you can, everyone is welcome to go through the book.
Okay. Thank you for that. One more question. Dr. Jayanti Lal is asking that, do you see syphilis nowadays in pediatric?
So not like earlier, not as commonly as earlier, but we do see it. So it is something which one should keep in horizon. So we would see probably, if earlier we could see a case of syphilis, congenital syphilis, say once in a month or something, now we see once in 6 months or a year. It's not extremely common, but it's not gone away. Syphilis is returning. So it is worth keeping that in the radar whenever you see those kind of manifestations. So manifestations are, in brief, just say that secondary syphilis, the congenital syphilis in children presents more as secondary syphilis would in adults. So you'll get these condylomata lata type of lesions in the genitals. You'll get sometimes a psoriasiform rash all over the body. You'll see palms and soles getting blisters and peeling off. So those are some manifestations of secondary syphilis in the skin.
Okay. We have one more question, that what are the skin presentations of HIV in pediatrics?
Skin manifestations of HIV in pediatrics. So the skin manifestations of HIV in pediatrics is more or less that HIV in adults. So you can get a whole lot of either. So basically, the problem is with the immune dysregulation. So either you will have a lot of autoimmune immune-related diseases like psoriasis, seborrheic dermatitis, etc. coming up, or you will have a lot of opportunistic infections. You will see molluscum contagiosum, which is huge, multiple, you will see severe forms of tinea. You'll see zoster, which is normally you don't see zoster so commonly, but a child getting florid hemorrhagic lesions of zoster. So if you see any infectious disease which is too florid, then one has to keep HIV in mind.
Yeah, thank you very much, sir, for your excellent session. I guess we have taken all the questions, and thank you once more. Right, that was really enjoyable session.
Thank you
we would
so
like
much.
to hear from you next onwards. And I'm going to personally call you for many times. Sorry.
Thank you so much, and I appreciate the enthusiasm of all of you. You all interacted well. You participated. That's great. Thank you very much.
Yeah, thank you so much.
Thanks.
Yeah, so we'll wind up Dr. Manish Shah's topic. Now we'll move on to our last speaker for today, and I would like to invite Dr. Saurabh Samantray. So Dr. Saurabh Samantha is also a new addition to NHSRCC. He is a senior consultant pediatric neurosurgery, and he has total 12 years of neurosurgical career. He did his neurosurgery and he has worked at many places, including Jerbai Wadia Hospital, and he has gone internationally to have this kind of pediatric neurosurgical exposure. He did multiple fellowships in Great Ormond Street Hospital, which is called Makkah of Pediatric Hospital in UK. He also did training in London, Birmingham Children's Hospital, and his areas of expertise are epilepsy surgery, oncology, brain and spine tumors, spina bifida, and hydrocephalus, and so on. So that's about Dr. Saurabh. I would like to invite you for today's session on pediatric neurosurgery. Yeah, Dr. Saurabh, over to you.
Thank you so much, Hiren. Thanks for the kind words. I'm really thankful, quite privileged and humbled to be talking to all of you today. So I'll share my screen. Is my screen seen well?
Yes, your screen is visible. Yep.
Okay, thank you. Great. So, yes, like Hiren said, I have been doing pediatric neurosurgery for the last 5 years in my 12-year neurosurgical career. But to be very honest, I mean, all across the world, and especially in India, when a resident is training in neurosurgery, the exposure to pediatric neurosurgery is really very, very limited. Most of us neurosurgeons are adult trained. And therefore, again, the services that neurosurgeons generally offer are mostly adult-based services extended or extrapolated to kids. I was not an exception. I finished my whole tenure of neurosurgical residency believing and assuming that pediatric neurosurgery was all about myelomeningocele and shunts. Until I happened to move into Wadia Children's Hospital and do my fellowship, and then of course things followed. To my surprise, I did realize that even in heavy pediatric hospitals, pediatric centers, the awareness about what pediatric neurosurgery entails and what the whole spectrum covers is really very limited. Therefore, I thought I should take this opportunity to maybe, briefly touch upon what pediatric neurosurgery covers and what is the whole spectrum, and then maybe put or throw some light on things that possibly would be relevant for you all. So therefore, like I said, the spectrum of pediatric neurosurgery basically covers spinal dystrophisms, hydrocephalus, brain tumors, craniofacial malformations, spasticity, vascular disorders, epilepsy, fetal neurosurgery, and craniocervical junction disorders. Obviously, due to want of time, I don't think it will be possible to really touch upon everything that is mentioned here, but maybe I'll cover a few topics which might be relevant to all of you. So moving on. Interestingly, the first thing that comes to any pediatrician or any neurosurgeon's mind when he tells a pediatric neurosurgeon is that this is a surgeon who treats spinal dystrophisms. Unfortunately, when we come across such a case in our practice, the general term that we use for all these lesions that I've shown here is possibly myelomeningocele. Someone who's a little more read or maybe more informed could possibly say, oh, is it a myelocele? And someone else, I've seen certain referral letters when I was in Wadia, which would come with a differential diagnosis of myeloschisis. To be very honest, I took some time finding my way out all of these lesions, and whether, at the end of it, when I was trying to read literature, I thought, is it really important to know what all these are? And like this person who's baffled and confused here says, does it really matter? So let's see whether it really matters, and whether all these lesions are different, and whether there are any other lesions in this whole gamut of spinal dystrophisms, and how they all behave, and what is the treatment and perspective that we need to have. Before I move ahead, I think I need to pay my respect to this person who's here. He is Professor Lichen Planus. I had the good fortunes of working with him at Great Ormond Street Hospital. For all us pediatric neurosurgeons all across the globe, he is like the father of pediatric neurosurgery. He has classified all that we know about neural tube defects. He has classified all the embryological subtypes, and he has advised and suggested treatments for most, if not all of them. In addition, his contribution to the other fields of pediatric neurosurgery is also legendary. So I have to mention, Pang is spinal dystrophism, so I have to mention about him, and I've learned so much from him that I have to really pay my respects to him before I move ahead. Anyways, before going into I'm sorry. Anyways, so before I move on to the various pathologies that we encounter, I thought I would briefly touch about the embryology that involves the neural tube formation. Now, interestingly, I think there are very few systems or disorders in the human body which follow the embryology, and wherein every stage of embryology is highlighted and brought about so emphatically and interestingly by the disorders that stand for them. So there are disorders of gastrulation, there are disorders of primary neurulation, and there are disorders of secondary neurulation. And just by looking at the disorder and looking at the MRI, you can know what went wrong when this baby or this human being was in his mother's tummy. So, like I said, neural tube formation can be roughly divided into 3 stages: gastrulation, primary neurulation, secondary neurulation. So the first stage, gastrulation, which happens around 2 to 3 weeks. It's very easy to even remember. Gastrulation happens around 2 to 3 weeks, primary neurulation around 3 to 4 weeks, and the secondary neurulation happens around 5 to 6 weeks. So like you see, as the embryo is being formed, in the beginning, this is the yolk sac, this is the amniotic cavity, and the embryo is a bilaminar disc. You can see there are 2 layers. This blue layer here, which is the epiblast, goes on to become the ectoderm later on. This yellow layer here, which is the hypoblast, goes on to become the endoderm later. So gastrulation is by definition a process which converts this 2-layered disc into a 3-layered disc. Obviously, this is a cross-section of the embryo that we are seeing. So when the blastocyst becomes from a 2-layered disc to a 3-layered disc, this process is called gastrulation. So now you can see the future ectoderm, mesoderm, endoderm. Now, the next stage is, again, if you see the ectoderm, mesoderm, and endoderm, there is a thickening in the ectoderm called the neural plate, which forms the future neural tube. So you can see it's folding inside. Now, gradually, as it folds inside, it will pinch off from here to form this tube. And then the ectoderm separates and the endoderm separates. And what is between the ectoderm and the endoderm is the mesoderm. So in short, the ectoderm will be forming the skin. In simple terms, this neural tube which formed from the ectoderm, so neural tube is actually formed from the ectoderm. This neural tube which got separated will form the future spinal cord. And here you have the endoderm, which is actually forming all the GI structures which are anterior to the spinal cord. And laterally and posterior to it, and also anterior to it, it's the mesoderm, which forms basically the dura, the meninges, and the vertebral bodies and spine. So this is primary neurulation occurring around 3 to 4 weeks. So the spinal cord from the craniocervical junction up to S2 level is formed by the primary neurulation stage. The last stage is the secondary neurulation stage. This is forming the spinal cord only distal to the S2 segment in the spinal cord. So the secondary neurulation stage has had some components of condensation, cavitation, degeneration, eventually leading to the formation of the conus and the chorda equina. So basically everything distal to S2. So the S3, S4, S5 and the coccygeal segments and the conus and the chorda equina are formed by the secondary neurulation. So once again, gastrulation 2 to 3 weeks, 2-layered disc to 3-layered disc, then primary neurulation 3 to 4 weeks, which forms the whole spinal cord from this 3-layered disc up to S2, and then secondary neurulation, which forms the conus and the chorda in 5 to 6 weeks. Now, all of this then later leads to this whole gamut of disorders called spinal dystrophisms. For rough understanding, let's classify spinal dystrophisms into two main categories, the open ones and the closed ones. Open ones primarily imply ones which have a big threat of leaking CSF because they do not have any covering over the neural tissue. So the open spinal dystrophisms are basically myelomeningocele. So basically, whenever we see anything on the back which looks like it might rupture, we call it myelomeningocele. But as you see in this whole flowchart, the myelomeningocele is just one component of the open spinal dystrophisms. Of course, myelocele, as the name suggests, is a disorder where you see the cord herniating. Myelomeningocele is a cord and meninges herniating. Hemimyelo and hemimyelomeningocele are basically, there are disorders which I will talk about later where there are two spinal cords instead of one. So if one spinal cord is exposed to the exterior, it is not covered by any other layer superficial to it, then it becomes the hemimyelocele and the hemimeningocele. On the other hand, we have this whole closed spinal dystrophisms spectrum. This is what we call the spina bifida occulta. This is the spina bifida aperta, which is the open, and this is occulta. Now, to remember, these are again some without a mass and some with a mass. So if you see a child with a lump on his back, but covered with skin, which can be normal or can have some abnormalities, which I will highlight later, then you have to see whether this mass feels fatty. If it is, then it could be possibly a lipoma, and then it could be a lipomyelomeningocele or lipomyelocele. As the names, there is a slight difference between the two, which I might explain, but at the moment it is not relevant. So basically, things with subcutaneous mass can be lipomas. Then at the same time, sometimes you can see a very dystrophic skin covering a meningocele. That time it won't be an open spinal dystrophism. It will then be classified as a closed spinal dystrophism. And then there is another rare but very serious condition called a myelocystocele. Now, the ones which happen without any mass are generally, now that is surprising. I think this is an eye-opener. We always believe that when there is a lump outside, there is a lump inside. But let's stand corrected today. It is not necessary that if there is a lump on the spinal cord inside, you will see a huge lump on the skin outside. No. I will show you all the cutaneous markers which represent spinal dystrophism so that the next time you do not miss it. Because many times I think the biggest error that happens in the diagnosis of spinal dystrophisms is that we see these innocuous little small markers and we believe that this could be a normal spot or a hemangioma or something, and we let the child go, and therefore the child misses that early window where there could have been an intervention and it could have made a world of difference to his neurology. So therefore, like I said, without subcutaneous masses, you can have these simple dystrophic states where like there is a spinal lipoma, like an intramedullary lipoma, a lipoma in the filum terminale, a dermal sinus, and a persistent terminal ventricle. Let's not get into the details of all of this. I just want to highlight that there are so many conditions without a huge mass also. And then there are these, syndromic conditions like caudal agenesis or segmental spinal dysgenesis. And like you've heard, the Vactal syndrome, the Oasis syndrome, where you have many systems involved. So basically the whole area, that is the distal part of the cord, is also getting formed with the urogenital organs. So therefore, any problem in the distal part of the cord, the conus, the cauda equina, also presents with other problems of the urogenital organs and those things, and with limb deformities, which present as caudal agenesis. These might also not present with a lot or with a big lump on the back, and there might just be urological manifestations to these disorders. This is again just to highlight what are the different spinal dystrophic conditions you can see. Anencephaly, where there is no covering on the skull and the brain is exposed to the outside. Myelomeningocele, myeloschisis, like I said. So myeloschisis basically by definition is when the spinal canal is exposed but remains at the skin level. Myelomeningocele is when the spinal canal is exposed but it is getting pushed by a collection of CSF beneath it. So that is why it is a myelomeningocele, because even the meninges are protruding out of the skin and the bone defect. Myeloschisis means neither the meninges nor the spinal cord which is exposed is protruding out of the skin defect. And then I talked about all of these here. Now let's go to this, which we will commonly see in our practice and which we will refer to possibly a neurosurgeon calling it a myelomeningocele. Now, just to take your attention to the slide that I showed you before, these are all lesions with supposedly fluid-filled structures on the back. Out of all of these, only this one is a myelomeningocele. Why is that so? I will go and explain in this slide. So you see, basically what has happened is, like I said, we have a tube formation which forms the spinal cord. If you can make out here, this tube, instead of being closed, is open like a book. And therefore, everything superficial to it is also not completely formed. Therefore, the skin around this is not formed. The bone around this is not formed. The dura around this is not formed. So there is a defect in all of it, going from skin to the spinal cord. I'll again go back to the neurology slide. If you see here, this was the skin, this was the neural tube, and this was supposed to form the meninges and the bone. So if this area is defective and exposed to the exterior, there'll be no skin, there will be no dura, there will be no bone, and this spinal cord, which is supposed to be a closed tube, will be open like a book. That is what we call, my dear friends, a classical myelomeningocele. And now you can easily remember that this is a primary neurulation failure, because like I pointed out in the slide before, it is happening at the stage of primary neurulation. Then you see an exposed neural placode, there is CSF leaking. Most of these myelomeningoceles need emergency repair, primarily because of the risk of infection, meningitis, ventriculitis, and also for the sake of facilitating care of the baby. These lesions, depending on what level they are in the spinal cord, can present with either paraplegia or paraparesis. I mean, if the lower these lesions are, so the lower these, say this is a sacral lesion or a lower lumbosacral lesion, all the nerve roots proximal to this lesion will be normal and would have exited the spinal cord. So therefore, say it is at a level of L4, L5, S1, the L1, L2, L3 roots would have exited. And therefore, a myelomeningocele baby with an L4 to S1 defect can still have proximal muscles which are normal. So this child can have normal hip flexion. But yes, this child might find it difficult to stand or possibly to move his lower limbs. Now, why I say so is because, it is sometimes very disturbing when these myelomeningoceles get counseled by the first consulting pediatrician. And again, I think the family gets told that there is no hope. Obviously, in an Indian setting where, rehabilitation, physiotherapy can all be very difficult, this can be a challenging problem. But remember, this is not a malignancy. This is not a cancer. I have seen patients coming to Wadia Hospital where they were told that the child will die. I don't think, if we are fighting tumors, if we are fighting cancers, if we are doing transplants, then I think this child deserves a life as well. I think that is a mindset that comes when you see these disorders and you see the long-term follow-up of these children. Of course, they'll need rehabilitation, but then we are not killing our cerebral palsy patients, are we? If not, then I think this myelomeningocele child deserves to live. This is a question which actually needs addressing in the Indian setting. Anyways, so now what classifies or rather what differentiates myelomeningocele from the other spinal dysraphisms is that there will be deficits in the lower limbs. I think there's some noise. Could someone mute the speaker, please? Yeah, thank you. This patient can be expected to have bowel bladder incontinence because the nerve roots going out at the lower lumbar or upper sacral levels, or the S2, S3, S4, the roots going to the sphincter will be affected, and so he can have bowel bladder problems. Therefore, he'll need urologist input as well. And most importantly, why myelomeningocele is different from other neural tube defects is because myelomeningocele is associated with Chiari-2 malformation and hydrocephalus. Almost 80% of these cases will have hydrocephalus and Chiari-2 malformation. That does not mean 80% of these cases will need shunts. But yes, when you see a myelomeningocele baby, I think what is more critical to prognosticate or to tell them is that it has to be closed. The function which is not there might not come back. But yes, if we close the tube and put it inside and cover it up properly, the functions of the roots proximal to them will not be deranged. And this child might in the future end up needing a shunt, but he'll need close follow-up. Now, there is this interesting thing because of which I think PANG is regarded worldwide. This is another thing called the limited dorsal myeloschisis. This all looks very, very, very complicated, but if you just focus on this one figure, I think you'll crack the embryology in 5 seconds. Like I said, in this animation again, this is the neural tube which was getting formed. This was the skin which was to be formed. These were the vertebral arches, the mesoderm, which were helping to form the rest of the dura and the meninges around the neural tube. This is the vertebral body. Now see, ideally, this tube should have closed, pinched off, and then the skin should have been a separate layer. However, if embryologically the whole neural tube stays open, then it forms a myelomeningocele. But if only a small area of the neural tube stays open, then it leads to the formation of what we call a limited dorsal myeloschisis. As the name suggests, only a very limited part of the dorsal surface of the myelo, that is the spinal cord, is exposed or unfused. That is why it is called a limited dorsal myeloschisis or an LDM. So my friends, LDM is as existent or as prevalent as a myelomeningocele. Obviously, the outcome and the prognostication of LDM is very, very different from a myelomeningocele, and therefore all bumps filled with fluid on the back need not be classified as meningomyelocele, because that will be criminal to the family and the patient, because LDM in general has a good outcome. Of course, it varies case to case. So like you see in LDM, what happens is part of the skin, therefore, because this pulled the skin inside, part of the skin goes right up to the neural tube. So basically, in the pathology or embryology, there is this cutaneo-neuroectodermal tract. So the outside part of the tract is skin, the inside part of the tract is neural tissue. So there is a tract connecting the skin to the neural tube. This is called an LDM. Now there is a difference. This LDM does not have a swelling over it, so it will be flat, which I will show how it will manifest clinically. But sometimes this central canal of the spinal cord might leak fluid through this tract. So you see fluid goes through this tract, and this forms a swelling on the back. This is a saccular LDM. This is what will look like a myelomeningocele. This is what I had shown in the first image, and which can confuse and which can make people think that it is a myelomeningocele. So this is the hydromyelic, the central canal of the spinal cord, which extends into this lesion. So like you see, LDM, one is a non-saccular or flat, the other one is a saccular LDM. So therefore, like you see, Pang has described all these lesions. These were all saccular LDMs of various types. We need not go into the detail. And these are non-saccular or flat LDMs. So they will have different cutaneous manifestations, which I will show in a better slide. But if you look at the MRI, it is so interesting. You see, this is the skin. This is the tract, which ideally should not have been there. This is a sagittal view of the MRI. So mind you, just to explain, we are looking at the spinal cord from the side, as if we are looking at the side profile of a patient. So if you see even here, this is the subcutaneous fat. The white signal here is the subcutaneous fat. Then from here, you can see a streak of tissue going in, and this gray thread here is the spinal cord. This one is the spinal cord. So actually, this is an LDM where there is, in fact, this has no swelling. So this is just subcutaneous fat. There might be a bump or a dimple or a crater there. But inside, if you go, the surgery entails opening up this whole thing, tracking this track all the way up to the spinal cord and disconnecting here at the spinal cord. Now, again, this becomes so critical because if you do not understand this embryology as a surgeon, there were times when embryology was not developed, MRI was not developed, and most of these dystrophic conditions got clubbed and put in one basket as myelomeningocele, and the only idea was just open, put a cover, and close it. Now, if you do not disconnect this streak of tissue from the spinal cord, you are doing no good to the patient. In fact, this patient, when he grows in height, this streak of tissue will pull on the cord, and this will cause cord changes and hence neurological deficits. So, but the family will always believe that something was done, and so they will never go back and follow up with a surgeon. This is what happens in most of the rural cases of spinal dystrophisms. They generally get treated by general surgeons or other surgeons who are not oriented about this tissue, oriented about this anatomy and embryology. And therefore what happens is they just open, provide a cover and close. But if internally under neuromonitoring and microscope, if this is not disconnected, we would rather do harm than good to the patient. So this is an LDM, like I said. It might need urgent repair if it is something like this, because it might rupture and leak CSF, but generally it has a good neurological outcome if you have preserved preoperatively. And the one differentiator between an LDM and a myelomeningocele is there is no association with hydrocephalus or Chiari-2. So the next time you see this, a swelling like this, remember to go back. A myelomeningocele, you will see a tissue which is open like a book. A spinal cord, which is open, which should have been in the form of a tube. Here, all of these are swellings full of fluid, which are just CSF, but none of them have any spinal cord or open book on the surface. Now your eyes can spot the difference between this and this one, where there's an open spinal cord. So this is the basic difference between myelomeningoceles and saccular LDMs. However, like I said, it's a big spectrum. We are then going to certain other things which are called split cord malformations. So just out of interest, you can see sometimes you can have a condition where there are two spinal cords. Again, this is generally a problem of gastrulation. And again, what you can see, this is a type 2 spinal cord malformation because there is CSF in between the two spinal cords. This white thing is CSF. So these are two spinal cords. We can never reunite them in one life, but this generally doesn't need anything doing. However, if you look here very closely, there are two spinal cords, but there is a bony bar in spinal cords. This is a type 1 split cord malformation. And for this entity, we need to open it up, go in between these two spinal cords. This is very critical, has to be done with neurooperative monitoring. We go in between these two spinal cords, remove this bar of bony tissue. Of course, we can't unite these two spinal cords, but once this bar of bony tissue is removed, then these two spinal cords are free. Now, the question that will arise is, why should this bar of bony tissue be removed? The reason for this bar of bony tissue to be removed is, if we do not remove it, again, it is causing tethering, meaning it is binding the two spinal cords around it. So therefore, when the baby grows, when the child grows, these spinal cords will be stretched along the bar. In fact, every time the spinal cord moves with respiration, it is hitting against this bar of bony tissue. And this is causing spinal cord changes and hence neurological deficits. So this is another type of dysraphism called a split cord malformation, commonly known as diastematomyelia and diplomyelia. Now, something else called the spinal cord lipomas. Because we have been talking a bit about embryology, like you see again, an LDM was very limited in its separation. A spinal cord lipoma, there is something else interesting that is happening. This is the problem with spinal cord lipomas. There is premature disjunction. So what is happening is that this neural tube has to first form a tube, then separate from the skin. But if it happens prematurely, that the neural tube is not formed, but the skin and the neural tube as a unit separate, and there is this big gutter here, what then happens is this internal surface produces a lot of chemical molecules, which will attract the mesoderm to grow into this gap. So what basically then happened is, the skin then eventually closed, but the mesoderm, that is the fat in the mesoderm, grew into the neural tube. This is a spinal cord lipoma. So therefore, you will see there is a separation line between the lipoma and the neural tissue. This is how a lipoma is formed. Obviously, what we see on the back is just the lipoma. But again, if this lipoma is treated only by dissecting here, but not going inside the spinal cord and separating the lipoma from the spinal cord, we are doing more harm than good. So this is the embryology of the spinal cord lipoma. Now, interestingly, I'll show you a few intraoperative pictures. If you see, this is a spinal cord lipoma. It is attached to the spinal cord surface. This is the conus medullaris. We have opened the whole bony canal. So the subcutaneous lipoma was going and getting attached to this dorsal surface of the conus medullaris. And these are all the cauda equina roots. You can see they're all emanating from here. So now the most critical part of this, therefore, is that you have to dissect all around this lipoma and separate it from that embryological line of fusion between the lipoma and the spinal cord to eventually what we should aspire to achieve at the end of surgery. So we have reconstructed a spinal tube. You can see stitches here. So it was an open tube. We have closed it into a closed tube. We have stitched it. We have removed as much lipoma as possible, and the roots are all preserved. This is something that Pang has been very, very vocally, talking about for the past 10, 15 years, and he has changed the way lipomas are operated all around the world. Otherwise, initially, what most neurosurgeons would do is that they would resect this lipoma halfways, remove as much as possible, disconnect it from the skin, and that they would think would, serve the patient. But the fact is, until this is attached to the spinal cord and the spinal cord is not reneurulated, this surface will again stick to the dura. That is something which will cause retethering. So therefore, Pang says that you should try, of course, there is a caveat to all of this. You cannot do radical resection in certain different types of lipomas, which I will not get into because that is very technical. But in general, the idea has to be to resect as much of the fat as possible and reconstruct a tube. So radical resection should be the aim. In fact, Dattling Pang goes ahead and says that if you cannot resect the lipoma radically, in such cases that I'm showing, you would rather leave it alone, because the natural history of an untreated lipoma, mind you, the natural history of an untreated lipoma is better than a half resected lipoma. So therefore, sometimes, although we try and go and do some shoddy job here, but if we leave the lipoma behind, then we are doing, again, hurting the patient more than helping him. So you see, this is a spinal cord. Again, we are seeing the spinal cord from one profile, from the side. This is the lumbosacral spine. So this is the lower end of the spine. So the spinal cord comes here, and then there is a big whitish tissue, which is the fat. Post-operatively, as you can see, there is no fat at all. This is the kind of aggressive resection. And for this, like a brain tumor surgery, you have to have pre-op scans and post-op scans to know what a sort of job you have done. So you can see this is the cord, this is the fat, this is an axial section. It is like a bread slice you have cut off. Here you see there is only these two small dots of fat, but otherwise the cord is reconstructed. So this is lipoma surgeries for you all. Now the next slide that I'm showing is more important because obviously this is what you'll be seeing in your clinic. So, there are cutaneous markers of spinal dystrophism. So as you're seeing here, this is a patch of tuft of hair. Obviously, if you see this, you should strongly suspect that, because there have been cases where there's a tuft of hair on the back, and all that the parents have been doing is shaving the tuft of hair. And then the child finally presents to a neurosurgeon's clinic with neurological deficits and bowel and bladder incontinence. Again, this can sometimes only be thought as a superficial sort of a port wine stain or something, and then not dealt with seriously. And then eventually it turns out to be that this is a hemangioma, which is a telltale marker of an underlying. When you see here again, now this is a lipoma. Now, again, this I think will generally get referred to a neurosurgeon. But again, here, if you see, this is the natal cleft. There is a pit here. This can be the starting of a dermal sinus tract or an LDM. A dermal sinus tract is very, very similar to LDM. It basically, like the name suggests, it is a sinus tract extending from the skin to the exposed spinal cord. Now, look at these smaller ones, which sometimes can be missed, especially in the Indian population, where sometimes, these flat lesions, the big lesions, the hairs, the fluid-filled sacs can be picked up. But these small lesions, where you're sometimes seeing a crater, you're seeing a very small capillary hemangioma or a small tuft of hair. Remember, if there is anything like this in the midline, you need to scan this patient and prove yourself wrong before assuming that everything is okay. So these are cutaneous markers of spinal dystrophism. Just to add further, if you see certain cutaneous markers, if you see, look at the slide on the right, are depictive of underlying malformation. So if you have a hypertrichosis, that means if you have a tuft of hair, there is a chance that you'll have a split cord malformation. Like I showed, you might have two cords beneath. If you have a sacral dimple, it might mean there is a dorsal dermal sinus. If you have a lipoma, that means that could be a lipomyelomeniingocele. And sometimes if there is no gluteal cleft at all, it could mean there is an underlying sacral agenesis. Now, when we talk about dystrophisms, I think this is something which has been a game changer for dystrophism surgery, for spina bifida surgery. It is intraoperative neuromonitoring. There are various modalities that we use, like somatosensory evoked potentials, motor evoked potentials, free-running EMG, and bulbocavanosus reflex. Basically, what we are trying to do is we are trying to, by SECPs and MEPs, we are trying to monitor the tracts. SECPs are the ascending tracts in the spinal cord. MEPs are the descending tracts in the spinal cord. By EMGs, EMG is the electromyography. So therefore, we are trying to monitor the nerve roots and then the muscles, the myotomes, which they subserve. And the BCR, bulbocavanosus reflex, is basically for the sphincter. So when all of these are monitored, and if any of this, because like I showed you in the lipoma, there were roots. So if, for example, one of this is a root that is going to the sphincter, and if I end up cutting it, I will lose sphincter function in a child who possibly had preserved sphincter function. So therefore, monitoring the sphincter, monitoring all the other muscles becomes very, very critical. And now, in the light of neural tube defects, you'll hear this very commonly. So what is tethered cord syndrome? So basically, tethered cord syndrome is not a disease, it is a syndrome. So like a syndrome suggests, it is like a constellation of clinical symptoms. So it's a clinical syndrome. It does not mean any particular disorder that I showed. Of course, I've not covered many in the slides before due to want of time. Tethered cord syndrome generally is when a child presents with neurological manifestations, that is motor sensory deficits, muscle atrophy. The child can have urological problems like sphincter disturbances, orthopedic manifestations, like various deformities in the lower limbs, spine deformities like kyphoscoliosis. Also, if you imagine, if there is something pulling on the cord from below, the cerebellar tonsils will sag from above. So cerebellar tonsillar herniation can also be a sign of tethered cord syndrome. And generally, tethered cord syndrome is seen in closed spinal dystrophism, because obviously in open spinal dystrophisms, you are not going to wait. Open spinal dystrophism basically means a myelomeningocele where you would operate up front, irrespective, and it is assumed that that spinal cord is stuck to the skin and everything. It is closed spinal dystrophisms where, unfortunately, sometimes we wait until the tethered cord syndrome develops, and then the patient presents to us. But unfortunately, by then, many functions are lost. So this was about the whole battery of spinal dystrophisms. Moving on to something next, which is closely associated with neurosurgeons, and that is this, hydrocephalus. Like it says, water in the brain. Running through the whole CSF pathway very, very slowly. Don't look at anything here that's written, just look at the figure that I'm showing. So basically, the brain has a lateral ventricle. This is again a side view, a profile view of the brain. It has a lateral ventricle, then there is a third ventricle, then there is an aqueduct, and then there is a fourth ventricle. Obviously, because we are seeing in the midline, we have two lateral ventricles which come into through foramina of Monro into a third ventricle that then flows into aqueduct into fourth ventricle. And then from the fourth ventricle, through the outlets of the fourth ventricle, CSF then circulates all around the brain, eventually circulating all around the brain and spine, and then gets absorbed in these midline structures called the venous sinuses. So again, running through the whole CSF pathway. CSF is produced by the choroid plexus, which you see pink over here and you see over here as well. So all around in the CSF, in the lateral ventricle, in the third ventricle, in the fourth ventricle, CSF is being produced. Of course, CSF is also being produced elsewhere, but these are the major seats of CSF production. Then that flow pathway is lateral ventricle, foramen of Monro, third ventricle, aqueduct, fourth ventricle, and then the convexity subarachnoid spaces, and eventually absorption into the venous sinus and into the blood, and through the blood into the heart. So this is the way the CSF flows. Now, what are the therefore various different types of hydrocephalus? Like I'm sure all of you know, there are the basic two distributions: communicating versus non-communicating, and congenital versus acquired. Now, running briefly through all the causes, remember these causes of congenital and acquired hydrocephalus can either be leading to, so congenital and acquired basically implies the mechanism by which this disease came into the body of the patient, whereas non-communicating and communicating are talking about the interruption of CSF flow that they are causing. So anywhere, if there is a block to this flow, say that means one of these arrows until this whole thing comes out here is blocked, that is an obstructive or non-communicating pathway. But suppose everything is flowing, but things are not getting absorbed, or if CSF is getting overproduced. So absorption is not a problem, but overproduction is a problem, like it happens in many tumors, like choroid plexus tumors. So absorption is okay, but the CSF, there is so much of overproduction that therefore the patient has hydrocephalus. All of that, or for example, where the absorption is hindered because of either blood due to hemorrhage or infection, like, bacterial infections, tuberculous infections, where the absorption here is affected because the subarachnoid spaces are scarred. So therefore here again, CSF flows, but it is not getting absorbed. So any problem in absorption is communicating, and any problem in the flow is non-communicating. So like we'll quickly run through it. It's aqueductal stenosis, Chiari malformations, Dandy-Walker malformations, vein of Galen malformations, and all of these can present with combinations of communicating and non-communicating. Neural tube defects, CNS tumors, like I said, they can compress, but at the same time, you'll be surprised, why am I calling a CNS tumor a communicating hydrocephalus type? Because CNS tumors secrete a lot of protein into the CSF. That makes the CSF turbid, like how it happens in infection, in TB, or in bacterial infections. When there is a lot of protein in the CSF can't be absorbed properly. So therefore, most of these conditions cause communicating and non-communicating. For example, a vein of Galen malformation, because of the high venous pressure, is obstructing the CSF absorption. That's why it is causing communicating hydrocephalus. At the same time, when it is very big, the vein of Galen malformation can cause direct mass effect and therefore causing a non-communicating hydrocephalus. Same is the case here: trauma, infection, hemorrhage, tumors, all causing, these are acquired causes. Now coming to the clinical part. Generally, most of the referrals for hydrocephalus come with there'll be a line on history which says child found with increasing head circumference. You would have measured the head circumference of the child and written it as 48 centimeters or something, and then sent it to the neurosurgeon. Mind you, what is more important, and I think this was something, I was into this practice, and I have to commit to it. Even when even during my days in Wadia, I would look at the main head circumference, and I sort of by practice knew that this head circumference is big for this child. But I would never really see how it was plotted on a growth chart. I would never make it a point, and I would directly jump onto the MRI. I think later on with experience, and when I went back, so in the UK, they have a trend of something like a red book. So they give a red book to all families, and the midwives and the nurses who are looking at the families in the community plot everything. Now, this was new to me. Maybe you all are aware of it, but this was new to me when I went there. And in the community, there is a growth chart being plotted on the red book. So if the head circumference is jumping centiles or crossing centiles, that is more important than an absolute head circumference. So for example, and I will highlight in this further, for example, this child. Now, why I'm saying that absolute head circumference is not critical or the clincher of diagnosis, because this child, as you see, the ventricles are not very big. This is an MRI, this is a CT, but this is a condition called benign enlargement of subarachnoid space. I'm sure in your clinic, you might someday see a child with macrocephaly who comes with this scan, and you will, I mean, of course, you should seek a neurosurgical opinion, but the fact is you will be surprised to think that why is the head large if the ventricles are not big? So this is in fact one of the most commonest causes of macrocephaly in infancy. I'm in fact writing a chapter on this, and so therefore I've done some review of literature on this, and this is one of the most common causes of macrocephaly in infancy. The head circumference stays above or parallel to the 90th to the 98th centile. So you'll always have big head circumferences. So now you see the point that I was making. Only a big head circumference doesn't make a child hydrocephalic. This, in fact, is also called external hydrocephalus, or, this is another term for because it is external to the ventricle. But generally, this is assumed to be a self-limiting condition. There is a transient developmental delay, but the child generally catches up. Of course, there are many reviews in literature now, like I was saying, where they have on complex neuropsychic, they find children with BESS to be wanting in certain tests of development. But in general, this is believed to be a self-limiting condition and does not require any treatment. So you see, sometimes only because the head circumference is big, you might, there might be an error in counseling of the family that because the head circumference is big and, somewhere it can get reported as external hydrocephalus, the family might end up believing that this will need some treatment. But most of these cases generally do not need treatment unless there is raised ICP. Then there's another condition called benign familial microcephaly, where generally a male sibling or a male family member has big heads despite normal sized ventricles. And there are other genetic and syndromic causes like achondroplasia, glutaric aciduria type 1, which will present with big heads. But also some of these causes picture like this, but they will not have hydrocephalus and no features of raised ICP. Therefore, this will be very, very different from the actual hydrocephalus. So more than head circumference, plotting it on a head chart and documenting jumping or crossing centiles is what helps a neurosurgeon decide whether you need to do anything, of course, in the light of other clinical features. Now, a very interesting slide. If you look at these three slides radiologically, because most of the times we neurosurgeons err on the side of treating scans. If you look at these three scans, this scan, you can see that's a CT. Of course, the first one is a CT scan. This is an MRI. This is a CT scan again. If you see this scan, the ventricles are big. This scan, ventricles are big again. And this scan, ventricles are bigger than what they are in this scan, right? Although this is also slightly enlarged, but you see these three. So these are three scans with big ventricles. Does that mean all three of them need shunts? No. So therefore, ventriculomegaly in itself is also not an indication for surgical intervention. So as I've titled here, this is acute hydrocephalus. So like you see, what distinguishes this scan from this scan is, on this scan, although it's an MRI, you see the ventricles are big, but you can see CSF signal. So this is white streaks here are basically subarachnoid spaces on MRI. So the pressure here is not so high. Therefore, this patient may have had some cause for hydrocephalus, but the process did not progress, and this hydrocephalus is a chronic hydrocephalus or possibly arrested hydrocephalus. So if this child does not show any signs of raised ICP, even if the ventricles are big and the head is big, I will not operate on this child, even though the ventricles were big. So I will err in my judgment if I put in a shunt, and there can be a catastrophe in this child if I put in a shunt. Similarly here, you see there is something here. So there is possibly a vascular insult or perinatal insult or something. So this is possibly a vascular territory stroke, a ischemic insult which has happened perinatally, and then therefore this area of the brain is lost, and hence there is an ex vacuo dilatation. So you see all these sulci which are seen here are way more prominent than what here it is. So when I see such a picture with big ventricles and a gliotic area or a defective area in the brain here, I realize these ventricles have enlarged because there is a lot of empty space in the brain. So this is called hydrocephalus ex vacuo. Again, this does not need a shunt. Of course, if this or this case again starts showing progressive ventriculomegaly in serial scans, I might then consider doing something. But now look at this scan. The ventricles are big, but can you see any of these sulci which you're seeing here, the subarachnoid spaces which you're seeing here in this scan? No. Now I think this difference will be staring you in your eye. This is a case of an acute hydrocephalus. It could be due to any cause. And this looks like a very tight brain, and therefore it needs immediate urgent CSF diversion. Means you have to put a tube into the ventricle and drain it. Where you drain it is a completely different question, but this needs CSF to come out. So this is why even ventriculomegaly is not a clincher of a diagnosis, nor is microcephaly. Now, a very short insight into what is a shunt. I know all of you know what shunts are, and but I'm just trying to simplify things. A shunt basically has three components: a ventricular catheter, a valve, and a distal catheter. Ventricular catheter, as the name suggests, will be going into the brain. The valve sits here behind the neck, on the neck behind the ear, and the distal catheter goes into the tummy. So this is the basic layout for any shunt. You have to have a ventricular catheter, which has to go into the ventricles, because obviously we are draining the ventricles. The distal component changes in the shunt. So for example, if instead of a ventricular peritoneal shunt, you have a ventricular atrial shunt, then this distal catheter, instead of going to the tummy, will go to the heart. You'll put it into one of the common facial veins, or maybe sometimes even into the IJV. Now, sometimes we can also do a ventricular pleural shunt. So everything else proximally stays okay, but you now put it into the pleural cavity, because that is also potential cavity. Obviously, that's a limitation in pediatrics, because generally ventricular pleural shunts, the shunts that I have done is mostly in adults or kids over 7 years, but that is a potential space for absorption. And then there are those historically described shunts where you put shunts into the gallbladder or the urinary bladder, which are not practiced anymore. So basically, going again back to so if you have to describe the shunt to a family, you will just say that the doctor will be putting a tube into the ventricle, then the tube passes beneath the skin. Everything is, so you just have one cut on the cranium, one cut in the tummy. There are no other cuts from the head to the tummy. So basically, one catheter from this cut goes to the ventricle, then connects to the valve. Now, this valve is the one that regulates the CSF pressures. And as hydrocephalus surgery progressed, I think there are more number of valves in the world today than there are number of or types of hydrocephalus. So, you have multiple number of different shunts and various contraptions which are available. No randomized control trial till date has proven that one type of shunt is better than the other. In India, we use something called the Chabra shunt, which is very, 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 very economical. It suits most of the patients. It costs roughly around $5,000, which is say 50 pounds. And in the UK, when I was there, obviously they didn't use the Chabra shunts. Most of their shunts costed somewhere around 700, 800 pounds, which would mean around $70,000 to $80,000, or sometimes even more than $1 lakh. And that's what a routine. So obviously in the Indian system, we have to tailor it. And there is, as I said, there is no trial which says that a Chabra shunt is inferior. Our experience here in India with Chabra shunts was phenomenal. And the problems that happened here was a similar kind of problems that I've seen at all the big centers that I worked at. So again, like I said, ventricular peritoneal, ventricular atrial, ventricular pleural shunt. Now, this is another shunt which I will talk about in the next slide. Now, if you see here, this is a ventricular space. And from the ventricle, the catheter comes. And this is the galea. Like, in neonates, you have a cephal hematoma or a subgaleal hematoma because of forceps delivery or a vacuum-assisted delivery. So the subgaleal space is a potential space. So what we do is, the ventricular catheter in any shunt has to have a ventricular catheter, like I said, but the distal part will end beneath the scalp. So what we are now doing is we are using the ability of the scalp to absorb the CSF. Of course, ventricular subgaleal shunts therefore will produce with a swelling on the scalp. But as far as the swelling is outside the brain grows, and therefore, it doesn't hurt the brain. So this is a ventricular subgaleal shunt. Now, again, like I said, as the child starts growing, the valve has to be sometimes fixed, because with increasing height you can have problems of over drainage. So when the child becomes taller, CSF starts draining more because of gravity. That time you might have to use programmable shunts. You use things called anti-siphon devices. I think the only thing which is established worldwide, especially after this path-breaking trial which basically was a British antibiotic and silver impregnated catheter trial. They have proven beyond doubt that if you use antibiotic impregnated catheters in VP shunts, you reduce the chances of infection. Now, unfortunately, therefore, in India, using antibiotic impregnated catheters for every patient is not possible. It is not economically viable. Although, as I said, we have never really, compared a study in India, but from my own experience, I can say that we have used non-antibiotic impregnated catheters since times immemorial, and I don't think the outcomes have really been affected a lot. But yes, many centers across the world, they have started using antibiotic impregnated catheters. In the UK, they use rifampicin and clindamycin impregnated catheter. So this is one thing which is proven, but otherwise there is no recommendation for one shunt over the other. Now, this is another thing I think which you broadly need to know. What are the types of CSF diversion? Basically, shunt is CSF diversion. We are diverting CSF from within the brain to outside the brain. If it is a permanent shunt, then it is a VP shunt or a VA shunt, or sometimes a subduroperitoneal shunt. Like the name suggests, you're draining the subdural cavity into the peritoneum. But there are certain temporary forms of CSF diversions. Why I'm saying this is because many times, these terminologies are confusing to the pediatric physician. So there is a ventricular subgaleal shunt, which I said, which is temporary. Then there is an external ventricular drain or an EVD, and there is a ventricular access device or a Umeya reservoir. It is very important for you to know what this VAD is, because, many times, even when I operate on a child, I might sometimes leave a VAD inside, and I might then expect that when the child goes back, if the child is in Mumbai and I'm stationed in Mumbai, they possibly see me. But the fact is, if the child is in Washim, if the child is in Balasha, I don't think they will have an access to come to Bombay at least for 24 hours. In that case, I can speak to the pediatrician there and ask him to tap the VAD or the Umeya reservoir. That's why this next slide is very important. So this I explained, ventricular subgaleal shunt. Now, what neurosurgeons sometimes do is they put in a reservoir into the ventricle. So like you see, this is a reservoir. There is a button here. This is like a collapsible, silicone button, it is similar to a chemotherapy port, if you guys have seen that. And then there is this catheter which goes into the ventricle. So what basically we have to do is, anytime there are any clinical or radiological signs of raised pressure, we can just use some sterile precautions, poke a needle, stick a needle into this, this reservoir, aspirate 20-30 mils of CSF. This is completely non-traumatic. This will not hamper the brain because a catheter to the brain has already gone into the ventricle. So we are not putting a needle into the brain at all. So therefore, you need not be scared of doing this tap. All that you need to do is you need to give complete asepsis, clean it well, and then with your proper gloves, like you would do with a central line, you tap this CSF. That is both therapeutic and diagnostic. So this is an Umeya reservoir, and I'm maybe sometimes in your practice you might come across a child with this reservoir, and sometimes tapping the reservoir can be life-saving. I have seen instances when the kids had a reservoir, but because no one knew what to do with it, they traveled all the while, but by the time they reached the hospital, the child was dead. So this tapping a reservoir is a simple procedure. You can feel it with your skin, with your finger. It lies beneath the skin, and you can tap it easily. Now, this is an EVD. This, of course, is something that is done within hospital conditions, and this is done by a neurosurgeon. But this is an external ventricular drain. So what you're doing is, if you believe that the child is not in the need of a permanent shunt, or even if the child needs a permanent shunt, the situations are not conducive. Say the CSF is infected, the proteins are very high, the sugar is low, or there is blood in the CSF. So you know that if you put a permanent shunt, the shunt will get blocked. In that condition, you put an EVD. Now, the external ventricular drain is something, again, catheter going into the ventricle, coming out, and attached to a ventricular drainage system. It's quite akin to a urinary drainage system like the Foley's catheter that we use. And of course, the only thing is you have to zero this system. So the external auditory meatus, or the tragus, is considered to be at the level of the foramen of Monro in the brain. And that is where the zero of this system is there. What is more important in this situation is also that, when the system is flowing, the height to which the CSF rises also talks about the intracranial pressure. This, in fact, is the gold standard way of measuring intracranial pressure. Of course, it has its side effects, it has its problems and chances of infection. So this is not what we routinely use for monitoring intracranial pressure. But if you have an EVD and connect it to a gauge where you can measure how high the CSF is rising from zero level, that will, so if it's rising 10 centimeters, that means the intracranial pressure is 10 centimeters of water. So anyway, so this is temporary CSF diversion. This is a modern development in management of hydrocephalus. Most neurosurgeons would offer, but obviously, the complications in pediatric neurosurgery are way more than what it is seen in adult. The conditions are different. The anatomy is very different. But yeah, this is a big tool in the hands of a pediatric neurosurgeon called the endoscope. So the basic advantage of an endoscopic third ventriculostomy or an ETV is that if you do it properly, you don't have to put a shunt. So basically, the patient is free of a shunt throughout his life. And obviously, a shunt is a hardware, and like a shunt is fraught with many problems like shunt blockages and shunt complications, shunt infections, shunt migrations, and therefore, if you can get rid of a shunt in a child, in a child who already has a shunt, or say if you do not need to put in a shunt and can treat the child completely with an endoscope, I think this is the preferred modality of choice. Of course, it comes with a few caveats. Just from a perspective of anatomy, for your knowledge, like I told you, the CSF pathway, you go with the endoscope. This is the lateral ventricle. This is the third ventricle. This is the floor of the third ventricle. This is the aqueduct. This is the fourth ventricle. Normally, CSF should have flown from lateral ventricle to third ventricle to aqueduct to fourth ventricle. But due to certain reason, if the CSF is not flowing across the aqueduct, tumor or aqueductal stenosis, then what happens is that the third ventricle and the lateral ventricle start enlarging. In that case, what we do is we put in an endoscope and we make a hole in the floor of the third ventricle. So now what we have done is, because this exit route was blocked, we make a new exit route and the CSF then starts circulating all around the brain from here. So we are still depending on the absorptive capacity of the brain to absorb CSF. We are just making a route for CSF to exit. Therefore, in cases where the absorption is poor, like infection and hemorrhage, ETV doesn't work that well. But in cases where the absorption is good and there is only obstruction to CSF, ETV works wonders. Therefore, it is the preferred modality of treatment in obstructive or non-communicating hydrocephalus like tumors and aqueductal stenosis. It has a poor outcome in post-infectious and post-hemorrhagic hydrocephalus because absorption has gone for a toss. And most critically, whenever you have a tool, you need to know when to use it and when not to use it. There are many criteria, especially one which is very famously called the ETV success criteria, the ETVSS. And one of the factors which the ETV uses is age. ETV done below 6 months of age generally does not work that well. And this, if not a thumb rule, is pretty much true in most cases. The reason for that is basically because the absorption of the CSF is not so developed until 6 months of age. Therefore, even if you make a route here, but if CSF absorption is not so good, ETV won't work even if your surgery was good. And most importantly, it can sometimes be used for shunt revision. So if a child had a shunt, but then later on you have to revise it, you can then, if the child has crossed 6 months of age, go ahead and do an ETV rather than revising the shunt. So this is what I try to talk about here. Now, one sort of hydrocephalus which is very critical from the pediatrician's point of view is the post-hemorrhagic hydrocephalus due to prematurity, germinal matrix hemorrhage. So, as you know, it is germinal matrix hemorrhage is classified into these grades as shown here. This classification, although is old and there have been many modifications to it, but the Papil's grading of intraventricular hemorrhage in premature neonates still holds good. At least it helps govern decisions. So, like you see, this is normal. The ventricles are small. This is although an ventricles are small. Now here, this is in ultrasound. What you're seeing here is you're seeing a grade 1 matrix. Germinal matrix hemorrhage, meaning the hemorrhage is only restricted to the germinal matrix. So germinal matrix is basically a normal structure between the in the chordothalamic groove. You need not bother about what that location is. If the hemorrhage is only in the germinal matrix, it is grade 1. Then as you see, hemorrhage extends into the ventricular system less than 50% without ventriculomegaly. So in grade 2, the hemorrhage has extended into the ventricle, but the ventricles are not getting enlarged, or less than 50% of the ventricle is involved. This is grade 2. Grade 3 IVH is when the ventricles have started becoming enlarged and the hemorrhage is also extending for more than 50% of the ventricles. This is grade 3. And the last one is when there is intraparenchymal bleed. So again, just summarizing, normal grade 1 hemorrhage means only the germinal matrix. Grade 2 means into the ventricles, but no big ventricles. Grade 3 means into the ventricles with big ventricles. Grade 4 means into the brain parenchyma. So this is the Papil's grading for neonatal prematurity. Now again, there are various schools of thoughts in terms of when you should treat post-hemorrhagic hydrocephalus in a neonate with prematurity. Various centers have various strategies. I think what is very, very keenly discussed, and I'm sure you'll appreciate this as physicians, is that the cystic periventricular leukomalacia, the periventricular hemorrhagic infarction, so the PVL, the PVHI, all of these things which occur around the ventricles in the brain. So basically, what people are trying to avoid is that the brain around a ventricle in a premature child is if I were to use a very simplistic word, delicate, and any dilating ventricle will cause mass effect, will cause ischemia, will release chemicals which might damage this brain and hence lead to PVL, periventricular leukomalacia. Also at times, bleeds can cause hemorrhagic infarction. And therefore, people believing in this school of thought believe that we should not wait for the head circumference to grow in a premature baby. Because like I said, in a normal hydrocephalus child, you will feel the fontanelle, you will feel the head circumference. If the head circumference is growing, you will do something, but if not, you will stay put. In preterms, many a times, even with enlarged ventricles, the fontanelle will be flat and soft, and the head circumference will not be growing. Then the question arises, should you do something? Again, there are centers. I worked in 2 centers. One center in the UK, the Birmingham Children's Hospital, was a heavy center, did not believe in intervening more because they thought large ventricles did not mean damaged brain. But there is literature from all around. So therefore, the Great Ormond Street Hospital followed this strategy. So I'm describing that. So what it says is, this is the Levine's ventricular index, very easily available on the net. So it says that the 97th centile is here, and this is the premature, this is gestational weeks in age for a premature baby. This is premature, remember. So if your head circumference goes to 97th centile plus 4 millimeters, so for example, say your baby is 30 weeks gestational age, corrected gestational age, 30 weeks. And his head circumference is 16. So 16 centimeters is higher than 97 plus 4. This is what Levine tried to say, that if your ventricular index is higher than 97 plus 4, you should do some form of CSF diversion. Interestingly, many a times, the centers who choose not to treat preterm IVH, they believe in a school of thought which says that the ventricular enlargement in IVH sometimes is transient. It goes on for a couple of weeks and then it stops. So then if we are not aggressive enough, we can avoid hardware in that transient enlargement. So therefore, what we used to do at the Great Ormond Street was that we did a temporary CSF diversion using lumbar punctures. Lumbar punctures, so we used to ask the neonatologist or the pediatrician to do a 10 mils per kg lumbar puncture. So, depending on the weight of the child, you can drain up to 10 mils. And after 10 mils, you repeat the cranial ultrasound. So the cranial ultrasound is a very handy tool. So after 2 lumbar punctures, if the head circumference still does not come down, then we would possibly think that this head circumference is not responding to lumbar punctures and this is going to be obstinate, and therefore we'll have to do something about it. And then we either go and insert a ventricular reservoir like I had shown, or we do a ventricular subgaleal shunt. So these are temporary CSF diversions, remember, because we are still not sure if this neonate will need a permanent shunt. And also in a neonate less than 2 kilograms, you cannot put a permanent shunt because the shunt will cause skin breakthrough and lots of complications. Also remember, these ventricles have blood, so the shunts will get blocked if you put shunts in a neonate with premature IVH. So therefore, in these cases, you put a temporary CSF diversion, ventricular reservoir, VSG, and eventually you do a shunt if needed. So this was about neonatal prematurity and PVH. Going on to craniosynostosis, I'll be quick. There are 2 forms of craniosynostosis, isolated or non-syndromic and syndromic. Isolated or non-syndromic means a single suture synostosis. I'll just show you the 4 most common forms of isolated or non-syndromic craniosynostosis are, the most common one is sagittal suture, followed by metopic, followed by unilateral coronal, followed by unilateral lambdoid. So like you see here, this is a child with a sagittal suture synostosis. I would want you to focus on the, the phenotype, the presentation, because I think one of the most critical points in referring a craniosynostosis child is the time of referral. Especially in this day and age, we need to do something when the bones are pliable, when the bones are malleable, rather than when the bones are, hard and well established, and then it entails a lot of blood loss, and the surgery also is much more difficult than when it is done in a smaller child. So therefore, this is the typical phenotype of a sagittal. You can see, as it's called a scaphocephaly, it is a boat-shaped skull. Look at here. This is the normal skull. These are the coronal sutures. This is the 3D CT. This is the metopic. This is the sagittal. Look at here. Look at the scan over here. You are seeing the coronal. You're seeing the metopic, but you can see the sagittal suture is stenosed. Because it is stenosed, the brain cannot grow in this direction. Therefore, the brain keeps going in the anterior-posterior direction, causing the scaphocephaly. So you have something called an occipital bullet here. You have a frontal bossing here, and you have this temporal narrowing here, like you're seeing. This is the phenotype of a sagittal suture synostosis. Now, coming to a metopic suture synostosis, to decide whether a child is having significant metopic suture synostosis or not, you need to stand behind the child and look at him from above. As you see, the forehead is triangular. That's why it is called trigonocephaly. Forehead is triangular, and when you're seeing from above, you can see the lateral supraorbital margins. This is classical trigonocephaly, and like you see here, the metopic is fused, and it's a triangular shaped forehead. And here you're seeing all normal sutures. So this is the phenotype of a metopic suture synostosis. There is something called a metopic ridge, which might sometimes cause confusions, but we have to be very careful. And obviously, you have to refer it where you just see a ridge. You don't see a triangular forehead. You just see a ridge. And a metopic ridge actually doesn't need any treatment. So, obviously, the patient, if you suspect either a ridge or a triangular forehead, you have to refer the child earlier, and then the craniofacial center will decide whether it is a ridge or a synostosis. Now, another common unilateral coronal synostosis, like you can see, one side is flattened, and therefore there you'll see this orbit will also have problems. This patient can also have squint, and therefore will need ophthalmological inputs. But like you see on the this is of course the scan of another patient. You can see the coronal suture on the left side is fused, whereas on the right side you can see that the coronal suture is patent. This is the phenotype and a radiology of a unilateral coronal synostosis. Then just out of interest, going to one or two syndromes. Cruzon syndrome, Apert syndrome. Cruzon syndrome, Apert syndrome, somewhat similar, although they are different genes. But you will see in Apert syndromes, you'll have problems in the digits. You'll have something like syndactyly and brachydactyly in Cruzon syndrome. So why is it syndromic? Is because, of course, there are many other manifestations other than the craniofacial problems. But the management changes here because it is not simply just remodeling the skull like here. Here you are seeing there is proptosis, there is exophthalmos, so you have to reconstruct the orbits, reconstruct the calvarium. But at the same time, you see there is mid-face hypoplasia. So this patient is going to need mid-facial surgery also, but that is done at a later stage, around 7 or 8 years of age, when the child has grown up and when the bones are more mature for them to be pulled apart and pulled in front. So what we do is we basically make cuts here. We separate the face from the brain, and then we pull the whole face in front and keep it under traction, so that, and this is needed because this mid-face hypoplasia causes an obstructive obstructed upper airway, and that contributes also to the intracranial raised pressure. Therefore, syndromic synostosis, children have raised intracranial pressure as opposed to non-syndromic ones, because like you see, you can imagine the tonsils are hypertrophied in these patients. The upper airway is small, the nasal passages are small, the maxilla is retracted, because of which the upper airway is small, and these children therefore especially have to have sleep studies to document whether the ICP is because of an obstructive sleep apnea or whether it is non-obstructive. Of course, non-obstructive can have its causes, but if it is obstructive, either because of the midface or the tonsils or the adenoids, then we either first the child undergoes an adenoidectomy, a tonsillectomy, then when the child grows up, we retract the face. So therefore, the management is a little more complicated. Now, going to the two major modalities of treatment for craniosynostosis. One is an endoscopic repair. It is generally done before 6 months. That is why I say the referral is very critical. If the child is crossed 6 months, you can't do an endoscopic repair because the child's bones are very thick. They are not malleable. I mean, thick, of course, thick, not so thick for like as an adult, but you cannot just in below 6 months in endoscopic, because it's minimally invasive. You just cut around the fused suture. You do not do a remodeling. So therefore, this is less blood loss, shorter operating times. The only issue with endoscopic repair is you have to use helmets, because what you do is you release the fused sutures and then you expect the helmets to remodel the brain. So that is what this is. Early referral is very critical. And the other is the open calvarial reconstruction. This is generally done after 6 months of age. Syndromic craniosynostosis requires multi-speciality team approach, and you have to do facial and cranial surgeries. Coming to the last bit, which is the epilepsy surgery. We are starting an epilepsy surgery program here at SRCC. I'll be joined by my able epileptologist, and we plan to start a pediatric epilepsy surgery program. I'll just be very quick and define what is intractable epilepsy. 2 or more seizures, 2 more than 2 years, 2 or more AEDs. However, this definition is applicable to adults. Pediatric epilepsy behaves differently. The main issue is, if you see in India, epilepsy, the burden of epilepsy is 10 lakh patients roughly. This is the 2014 statistics. Of these 10 lakh patients, at least 5 lakhs are potential surgical candidates. But the number of epilepsy surgeries happening in India, according to a 2016 statistic, is 700 to 800 per year. So while you have 5 lakh patients waiting, you are doing only 700 to 800 epilepsy surgeries per year in this big country. Pediatric epilepsy forms 40% of this whole population. Therefore, pediatric epilepsy center is a must. We are trying to establish one in our country. So these are the reasons why early surgery need to be done, because ongoing seizures cause cognitive decline, and also brain plasticity is a thing which is very critical, and therefore surgery needs to be done at an earlier age. These are the various surgical procedures that can be done: cortical resection, amygdaloidectomy, hemispherotomy, vagal nerve stimulation, corpus callosotomy. These are the pathologies: focal cortical dysplasias, tumors, Sturge-Weber syndrome, hemimegalencephaly, Rasmussen's encephalitis. And finally, these are the outcomes. This is the question that I'm always asked. Is the outcome of epilepsy surgery good? You can see for yourself, temporal lobectomies, the seizure-free freedom is 70 to 80%, hemispherotomy 80 to 90%, and all the others as well. So basically, if you're a well-selected patient, epilepsy surgery has good outcome. We have a lot of tools which we use in evaluation of epilepsy, like this is a SysCom, a subtraction ictal spect co-registered with MRI, which we do routinely to decide the epileptic focus, where an interictal spect and ictal spect are subtracted from each other. This is fusion of PET MRI with MRI and correlation with SysCom to diagnose this lesion, which is then resected. We do intraoperative electrocorticography, where we monitor the brain and decide how much to resect and where to resect. It also helps in brain mapping. We do intracranial EEG monitoring. So when the scalp EEG doesn't give you information, we put electrodes inside the brain to do intraoperative EEG monitoring, and we also use it for seizure stimulation and radiofrequency ablation. We have tools like the neuronavigation, which is basically the GPS system for the brain, where we register the brain surface to a computer, which helps us to find the lesions within the brain. This is a new modern tool. We have stereotaxy, which helps us put electrodes into the brain. So epilepsy surgery is safe, good outcomes can be achieved in properly selected patients, and it has a great demand in the Indian perspective and globally. For want of time, I think I'll run through the types of tumors. These are the various tumors seen. All tumors are not malignant. There are many diagnostic tools which guide treatment today, and many syndromic patients which present with tumors. One last line on fetal neurosurgery, which is modern and which is upcoming. Hopefully, we are looking to start that in India. Right now in neurosurgery, fetal surgery is done only for in utero repair of MMC. This was a landmark trial published in 2011, MOMS trial, Management of Myelomeningocele Study in 2011 in the NEGM. It says that the repair has to be done before 26 weeks of gestation, and it can improve neurological function. And the greatest advantage is it reduces postnatal hydrocephalus and Chiari-2 malformation. Remember, like I told you, 80% of these patients can have hydrocephalus and Chiari-2 malformation. However, in India, to do a fetal neurosurgery, PCP&DT Act is a roadblock. So you have to have your paperwork strong before you plan to start it. Let's hope we do something in the future. Thank you so much. Sorry for slightly overshooting, but unfortunately, I was trying to cover as many aspects of pediatric neurosurgery, and I still know that I've left out quite a few. But hopefully, this was of some information to all of you, and I'm really looking forward to working with all of you in the future. Thank you so much.
Thank you, Dr. Saurav, for wonderful lecture. You have covered everything which is possible in pediatric neurosurgery from A to Z. That was really very comprehensive. And I would like to take any questions. The response is very good. Everybody's praising your session. Let me see any questions are there. Anybody have a question? They can unmute themselves and ask question. You want to say, Dr. Saurav, anything regarding the epilepsy program that you are going to start or something?
Yes. So, we plan to start a pediatric epilepsy surgery program here at SRCC, in addition to doing the rest of the pediatric neurosurgery that we are doing. Obviously, pediatric epilepsy surgery has a big demand in India. There is a big population of drug-resistant pediatric cases which are awaiting surgery. So, I'll be joined by Dr. Pradna Gadgil, who's an able epileptologist, and together we plan to start a level 3 center. It is very important, therefore, to increase awareness in pediatricians and pediatric neurologists and in the community about the fact that 1/3 of epilepsy cases are surgical candidates, and there is no point bombarding those patients with drugs, whereas those patients can have a good outcome if we offer them surgery. And I think, considering that this is one of the pediatric super specialty hospitals in Bombay, I think this is one of the best places to run a pediatric program, because you have support from all units, including radiology, intensive care, neurophysiology, and rehabilitation, because it is a teamwork. Pediatric epilepsy surgery is a teamwork. But I'm really stoked and excited to see where the pediatric epilepsy surgery program goes. And I'm hoping to serve as many patients as possible in the future.
Yeah, of course, it will be a successful event. And I guess if there are no questions, then we can wind up today's session. And all the speakers were very good today. I would like to announce the next masterclass topics right now. So we have got the list. So next masterclass, we have got again 3 super specialists, in which the first will be Dr. Ruchira, who is our pediatric hemat-oncology specialist and bone marrow transplant specialist. She will be speaking on the approach to hyperosplenomegaly in children. And our second speaker is Dr. Shruti Bajaj, who is genetist, and she'll be talking on the rare is not so rare, that topic. And the third speaker of next session would be Dr. Amit Nagpure. He will be speaking. He's a pediatric surgeon here at SRCC, full-timer, and he'll be speaking on the approach to inguinal conditions in children. So I would like to invite everybody on the next month masterclass. And I hope today you would have enjoyed all the topics and the information which was shared here. And we can see the response. Response is very good. So thank you once again. Thank you once again, Dr. Saurav, and all the speakers who have given their contribution and this knowledge. And good evening to all. Yeah.
Thank you
By
so
that,
much. Thank you so much. Have a good day. Thank you.
Yeah. Have a good day. Okay. So goodbye to all. Thank you.
Bye. Bye.
Bye. Bye.
Bye.